Dear colleagues, it is my great pleasure to welcome everybody to our annual case reports in ophthalmology meeting this year, 2023. This is organized by our Foundation for the Ophthalmology Development, Ophthalmology 21, University of Warmia and Mazur in Austin, and the company Mark 21. I would like to highlight our sponsors who are always necessary for any conference. Here it is Viatris company, TEA, Oculus, and Topcon Healthcare. And our media patronage, there are some Polish magazines like Przegląd Okulistyczny and Medycyna Praktyczna and Optyka, and international ophthalmic magazine, The Ophthalmologist. I would like also to shortly introduce our team of the foundation, Ms. Natalia Galus, Mr. Szymon Wilkanowicz, and Maciej Szymański, very much involved in organizing this meeting. This year, we have speakers from 10 countries, including US, UK, Ukraine, China, Philippines, Israel, Poland, Portugal, Germany, and Puerto Rico. We this time divided the conference into topic sessions. The first session is on the retina, new challenges in the retina, and it will be moderated by Professor Maciej Gawęcki from Poland, Professor Nicole Eter from Germany, and Professor Stephen Schwartz from US. The second session on ocular surface will be moderated by Professor Anna Machalińska from Poland and Dr. Agnieszka Kardaszewska, also from Poland. Session number 3, Enigma cases, will be moderated by Dr. Agnieszka Kardaszewska from Poland, Professor Ferenc Kuhn from Hungary and US, and Dr. Perfecto Kakampen from Philippines. And finally, the session number 4 on myopia and new therapy methods. I am pleased to moderate this session together with Professor Carla Lanka from Portugal and Professor Yair Murad from Israel. And now, this is my great pleasure to introduce this year KSAWERY lecture that is entitled The Importance of Case Reports, and it will be delivered this year by Professor Stephen Schwartz from Bascom Palmer Eye Institute, Miami, US. Professor Stephen Schwartz is a professor of clinical ophthalmology at the University of Miami Miller School of Medicine. He's also a medical director of Bascom Palmer Eye Institute at Naples, Florida. And he serves on the editorial boards of case reports in ophthalmological medicine, Medicina, and Scientific Word journal. His areas of expertise include macular diseases, vitreoretinal diseases and surgery, diabetic retinopathy, macular degeneration, and related disorders, retinal vascular diseases. He is an author and co-author of over 180 articles in peer-reviewed journals, including 30 case reports and small case series, 40 book chapters, and 2 books. We are so happy to have today Professor Schwartz with us as an invited lecture for KSAWERY Gawęcki lecture, please.
Okay, well, thank you. My name is Stephen Schwartz. I'm with Bascom Palmer Eye Institute. I live in Naples, Florida. I am delighted to present the 2023 GALEZOWSKI lecture entitled The Importance of Case Reports. I have no conflicts of interest. I am delighted to yet again collaborate with my good friends Andrzej, Grzybowski. Here's the two of us at the Retina Society meeting in London, 2019. We did sneak out of the meeting to go visit the Rosetta Stone in the British Museum. Always a pleasure to collaborate with Andrzej. Dr. GALEZOWSKI was a pioneer in ophthalmoscopy and ignopuncture, which was an older treatment for retinal detachments. He taught many, many students, including Paranod. He founded a monthly ophthalmic journal, so he was a clinician, a teacher, a scientist. That's really all we can ask of any of us. Prior GALEZOWSKI lectures by Dr. Bandello from Italy and Dr. Wang from China were very scholarly topics. I thought I would do something slightly different, maybe more in keeping with the spirit of a case reports conference. I'm going to talk about case reports and why they're good to present, good to write up, good to publish. And I hope every one of you will go out and present a case report after you hear this. I still enjoy presenting case reports. Here's me last February in Miami Beach at the Macula Society meeting, and I'll show you that case a little later in this talk. So I think there are 4 benefits of case reports, right? Anyone can write them. You learn by writing them. They help you make friends, and maybe most important, they teach you humility. So we'll start with anyone can write them, and I do mean anyone. We all see patients, so all you have to do is pay attention. If you see enough patients, sooner or later you'll see something interesting, or there'll be some different facet, there'll be something you can report. This is the first case report I ever published. I was a fellow at Baylor College of Medicine in Houston, Texas. I was the retina fellow on call, the intensive care unit called. They had a patient with thrombotic thrombocytopenic purpura. She became encephalopathic. When she recovered in the intensive care unit, the first thing she said was, "I can't see." The examination showed pallor of the optic nerves in each eye, attenuated and sclerotic retinal vessels in each eye. There was retinal whitening and cherry red spots in each eye, but there were also multiple intraretinal hemorrhages in each eye, with very little dye perfusion in the fluorescein angiogram, even in the later frames of the study. So the clinical appearance is consistent with a bilateral combined central retinal artery, central retinal vein occlusion. It's a very striking picture. Unfortunately, it was a very unfavorable outcome for the patients. There's a lot to learn from this case. We sent it to the Archives of Ophthalmology, and it became the cover image of the September 2000 issue. And then after that, I was a fan of case reports, and I hope you will be too. As a follow-up, 7 or 8 years later, I was in Florida with Bascom Palmer, and I was asked to see a patient who had a very similar history, thrombotic thrombocytopenic purpura, encephalopathic, woke up in the intensive care unit and said, "I can't see." The fundus appearance is really very similar. Bilateral cherry red spots with bilateral intraretinal hemorrhages. Very, very little dye perfusion, even in the late frames of the fluorescein angiogram. So maybe not quite as severe as the previous case, but I looked at this, I said, I've seen this before, I know what this is. Once you present a case, you own that case. You know it forever. You'll never miss it again. Which segues us into my next point. You learn by writing the case reports and by presenting them. Things that you didn't know before, by the time you're done presenting it, you'll know it, you'll never forget it. Here's a young patient. She was age 11 at the time of this visual field. She had had neurologic disease. She had a craniotomy, and she was left with a left superior homonymous quadrantenopia, which is not unexpected given the history. We, to be thorough, did a macular OCT, And then you really have to ask yourself, is this a normal OCT? And I could see how if you're moving fast in clinic and you're seeing a lot of patients, you might pass this as normal. But ask yourself, is it really normal? We'll come back to it. Here's the left eye. Again, it sort of looks normal, but is it really normal? Well, I think it's always good to look at the maps on the OCTs. So here's the map on this patient, and you can ask yourself, is this map normal? And maybe it's difficult to interpret with the infrared image overlaid or underlaid under it. So we could strip out that infrared image and just look at the maps. Are these normal maps? Well, the yellow part, right, which is on the right part of each eye, so on the nasal part of the right eye and the temporal part of the left eye, implies that half of the fundus, half of the macula, is thicker than the other half, and it's very symmetric. Can you see that? It almost looks homonymous. In fact, if we compare it to the visual fields, you'll see it really looks like homonymous thinning of the macular OCT. So this has a name. This is transsynaptic retrograde retinal degeneration detectable by macular OCT. This doesn't happen in every case, but if you check a macular OCT in enough patients with homonymous visual field loss, you'll see this, and it's interesting, and you'll never forget it. Now let's go back and look at those OCTs again. Is this really a normal OCT? Well, here's the right eye. I would argue that the temporal macula on the left side of the image is thinner than the nasal macula. And it's not diffusely thinner. What it is it's missing the inner retina. The inner retina on the left half of that image isn't there. So that's where the ganglion cells are, right? That makes sense. And when we look at the left eye, you get a very similar picture. Here, the temporal macula is thicker and the nasal macula is thinner, and it really is the inner retina that's thinner, right? Homonymous macular thinning, transsynaptic retrograde retinal degeneration. Case reports help you make friends. I have friends to this day from collaborating on small case series. Here's a case that I saw in Naples. This is a patient with neovascular age-related macular degeneration. You can see the hemorrhage. I started treatment with anti-VEGF drugs. After several anti-VEGF injections, the blood mostly went away and the macular appearance improved. But is there anything else that looks odd in this picture? Can you see anything that maybe catches your attention on this fundus photograph? Maybe it'll be easier to see if we put the two images side by side. So let's do that now. So we have the pre-image on the left and the post-image on the right. Can you see it? It's the optic nerve. The optic nerve has become swollen. I can prove that to you with a fluorescein angiogram. Right, early frame on the left, late frame on the right. See the leakage from the optic nerve? So this is an anterior ischemic optic neuropathy. This patient got a workup. This patient did not have giant cell arteritis. So this is a non-arteritic anterior ischemic optic neuropathy. I presented this case at the American Society of Retina Specialists meeting in Boston. And one of the doctors in the crowd introduced himself to me, said, "That's a very interesting case. I am collecting cases of vascular events in patients receiving anti-VEGF drugs. Would you share the case with me?" So of course I said yes. So Professor Mansour and I and a few other colleagues had presented a series of 8 patients with non-arteritic anterior ischemic optic neuropathy following anti-VEGF injections. And to this day, I get occasional emails from Professor Mansour asking me, do you have a case of this or do you have a case of that? So here's the case that I showed at the Macula Society meeting earlier this year. It's a patient with central serous chorioretinopathy. There are macular pigment alterations. It doesn't look very striking on the color photo, although the autofluorescence shows more pigment alterations. This was the patient's better eye. He was very, very symptomatic. Here's the fluorescein angiogram with multifocal areas of leakage. Here's the indocyanine green, similar areas of multifocal leakage. Here is the OCT, multiple cuts showing subretinal fluid. And in that bottom slide, there's a tiny little pigment epithelial detachments under the subretinal fluids. This patient wanted treatment. He was very unhappy. I treated with half-fluence photodynamic therapy with verteporfin. The next day, he said, my vision's worse. We looked at him again. He had much worse subretinal fluid in the right eye. See that? It's even more prominent on the autofluorescence, but the OCT was very, very striking. See, much worse subretinal fluid, although there are areas where the retina is trying to hang on to the pigment epithelium. And this image at the top here, with the little gold star, is the most interesting image of them all, because there's fluid in 3 separate compartments in this image. There's no fluid in the retina, no intraretinal fluid, but there's subretinal fluid, there's a tiny little pigment epithelial detachments, and there's a little wedge-shaped piece, right, almost exactly in the center of the slide, where there's little strands of the retina trying to hold on to the pigment epithelium, and there's a little space created. That little triangular space has a special name on an OCT. It's called a bacillary layer detachment. It's really a split in the outer retinal layers. So personally, I think it's more like a schisis than a detachment, because the retina really is attached in that point. But it's become called a bacillary layer detachment, and that's what it's known as. You can see bacillary layer detachments non-specifically in various exudative retinal detachments. I think you can see a little bit of it towards the center, that little V shape in the upper image. So this is a serous exudative retinal detachment following half-fluence photodynamic therapy for central serous chorioretinopathy. It has a bacillary layer detachment, which again is that downward-facing triangular image that you can see. And we're collecting a series of bacillary detachments associated with central serous chorioretinopathy, either natural history or post-treatment. Finally, case reports teach you humility. There's a case I'll never forget. There's subretinal fluid and exudates in the macula and superior and nasal to the optic nerve. Really no blood to speak of. This patient did not respond well to anti-VEGF. Fluorescein angiogram shows profuse leakage of both fluorescein and indocyanine green dye right next to the optic nerve. I thought initially this was a peripapillary choroidal neovascular membrane, but again, it really didn't respond well to anti-VEGF. Here is the OCT with a slice through the apparent fluid superior to the nerve and another slice through the center of the retina. I didn't know what to do with this patient. I showed the patient to a very senior colleague who said, maybe this is a neuroretinitis, right? There's a lot of fluid and leakage adjacent to the nerve. Let's evaluate for neuroretinitis. Interestingly, the patient had positive syphilis serologies and was also positive for toxoplasma. The patient was hospitalized, treated for neurosyphilis, and then promptly became lost to follow-up. I presented the case at a conference as a syphilitic neuroretinitis, and it's the first time in my whole career I was rejected by the audience. My favorite comment was, well, it was nice of you to treat as neurosyphilis, but we still have to diagnose the eye disease. So let's go back and take another look. And I think the key point here is that isn't really fluid that cut through the lesion superior to the nerve. That really looks like a solid lesion on the OCT, not so much subretinal fluid. So now we need to change our thought process and think about solid tumors adjacent to the optic nerve. Here's another example of the same diagnosis. If you really squint on that fundus photograph, there's a pinkish lesion just superior to the optic nerve. This patient looks a lot like my patient's. Profuse leakage of fluorescein dye and a solid lesion on the OCT. This is a retinal capillary hemangioma. It is very, very frequently misdiagnosed as a peripapillary choroidal neovascular membrane or a central serous chorioretinopathy. There's exudate, there's fluid. You may or may not see the actual lesion. There usually is not blood, and it usually does not respond well to anti-VEGF treatments. So case reports, anyone can write them. You learn by writing them. They help you make friends, and they teach you humility. And I thank you very much. Let's see some more cases.
In the right place?
Oh, yeah. So thank you
Yes.
so much for this great lecture. And finally, it's so good to have you with us today. We had some technical problems. I was not aware. I was not sure if you are finally with us. So good to have you. Thank you so much for all of these arguments why we should care about case reports. I can add some additional arguments. I'm not sure if you can see my slide. This is we share with Professor Schwartz for many years the interest in the history. So I just wanted to use the citation coming from Sir William Osler, who said, always note and record the unusual. When you have made and recorded the unusual or original observation, publish it. We wait for the questions from the audience in the meantime, and may I have another slide? I would like to highlight that some of the case reports became the first descriptions for the disease, like, for example, AIDS description. You can see it here. It was published in the American Journal of Dermatopathology as a case report in 1981. Steve, I have a question. So, when do you know that the case report is, let's say, worthy to be reported at the meeting? This is the first question, or it is worthy to be submitted and published?
Well, before I answer that question, right, I did not know that the first description of AIDS was in a single case report. You may know that the first publications on the use of bevacizumab or Avastin to treat retinal disease were two individual case reports by Phil Rosenfeld in Miami. One was a exudative age-related macular degeneration case, and the second one was a central retinal vein occlusion. They were published side by side in the same issue. So that's what really launched bevacizumab. It wasn't a clinical trial; it was a case report. But I would say that you have a publishable case report when you see it, and maybe that's not an easy answer, but when you go to enough meetings like this and you read enough case reports in the journals, after a while you'll get a sense of things that everybody knows and things that maybe not everybody knows. And sometimes it's a new or unusual facet of a disease, or sometimes it's a unusual response to treatments or side effects. And sometimes it's just a particularly nice example of it, but it'll catch your attention and you'll know. Always good to do case reports with other colleagues, right? Case reports tend to be cases that it took a few of you some time to figure out. And don't be afraid if you get it wrong, because I've done that, which I've shown you.
Thank you. Just to show, to honor you, I'm wearing the American tie. I'm showing it. It's an American Journal of Ophthalmology tie, especially for our American KSAWERY Gawęcki lecturer for today. Thank you, Steve, so much. Professor Schwartz will be also moderating the discussion after the first session. So, this is the time we need to move to the first session now. So if you have any question for him, then you can still put them in the chat, and we will discuss them during the discussion after the first session. Now we need to move. Thank you. And then I would like to ask our, let's say, moderator, Professor Gawęcki, who will introduce to the first session now, please.
Hello, everybody. So Stephen was already introduced by Andrzej, so that's done. I would like to introduce, well, the other moderator. I don't know if Nicole Eter from Germany is with us. So she's supposed to be the other moderator. However, I would like also to introduce all the participants who prepared case reports. And forgive me for my pronunciation because we have 3 lectures from China, Dr. Jiao Ji, then we'll have Dr. Adriel Vincent from Philippines, then Dr. Jiao from China as well, and the 4th lecture will be Jiang from China as well. That will be the first part of our session, followed by the 10 minutes discussion. The second part will be started by Dr. Dmitrii Bagautdinov from Germany, followed by Polish speakers Magdalena Ulińska and Magdalena Kai. I will present one case report, and we'll also have Dr. Mariana Karam from Bascom Palmer from USA. So thank you again, all the participants, and for all the effort putting the preparations of the case reports. I think we can start with the first one.
It's my pleasure to have this opportunity to share an interesting case that I have encountered in clinic. This is a case about an unexpected significant hyperopic shift after cataract surgery in a highly myopic patient. I have no conflict of interest. A 56-year-old man was referred to our clinic for complaining the decreased vision in both eyes for 1 year. He has a history of high myopia. After examination of slit lamp, we find a significant lens opacification of both eyes. Thus, we diagnosed highly myopic cataract. First, we led the patient to do the examination of manifest refraction. The results showed the best corrected vision acuity was 20/50 in both eyes, which proved that he had a significant vision impairment indeed. Then, we also examined macular OCT and B-scan. The results were all normal. So, in order to improve the vision, we recommended this patient to receive cataract surgery on both eyes, and the patient agreed. Thus, we further did routine examinations for cataract surgery, including examination of ocular biometric parameters using IOL master. The results showed that this patient had an extremely long axial lens. Before surgery, we used the Barrent Universal 2, which is more accurate calculation formula for high myopia so far to calculate the IOL power. At last, we first performed thecal emulsification with in-the-bag implantation of a monofocal IOL with 3 diopters on his left eye, with predicted refraction of -3.03 diopters. After 1 week, we did cataract surgery and implanted a 4 diopters of IOL on his right eye, with predicted refraction of -3.39 diopters. The operations both went very well. 1 week after surgery, the best corrected vision acuity both were 20/20. The patient was very satisfied. The manifest refraction showed that the spherical equivalent was -3.125 diopters in right eye and -3 diopters in left eye, which were similar to our predicted refraction. However, 3 months after surgery, he came to my clinic again and complained that it's hard to see things close up. After examination of slit lamp, we only find some degree of opacification and the contraction of anterior capsula. Further, we sent the patient for the manifest refraction. The results showed that the best corrected visual acuity of both eyes were good. However, the right eye showed a spherical equivalent of only minus 1.75 degree of diopter, and the left eye showed a spherical equivalent of minus 1.50 diopters. We were surprised to find that both eyes had an unexpected significant hyperopic shift compared with that 1 week after surgery. Thus, we wondered what caused these adverse hyperopic shifts. As we all know, actual position of IOL is a main determining factor of postoperative refraction. Thus, we used a novel UBM arc scan Insight 100, which could depict entire anterior segment in a single image and was less invasive and less time-consuming to observe the actual position of IOL in this patient. Through this examination, we could see intuitively the IOLs of both eyes showed severe backward bending. Thus, we speculated that the capsular contraction caused the backward bending of IOL, which led to the obvious hyperopic shift in this patient. Finally, we can only suggest this patient to wear a pair of reading glasses when looking at close things. Thus, this patient had to wear two pairs of glasses alternatively, and this was different from his previous habit. He felt very uncomfortable and was unsatisfied about the surgery. So, there is a question how to avoid this situation in the future. Actual position of IOL is a key point of refraction, determines the refractive outcome after cataract surgery. After surgery, actual movement of IOLs will lead to effective lens position change, which would cause refraction change finally. Forward movement of IOL, which is close to cornea, would cause myopic shift. Meanwhile, backward movement of IOL, which is close to retina, would cause hyperopic shift. So, maintaining the stability of actual position of IOL is a key point to avoid refractive shift after cataract surgery. In this case, the most important reason for the backward bending of IOL is because the patient is with extremely high myopia, so the power of implanted IOLs were very low and had more severe capsular contraction after surgery compared with emmetropia. According to this conjecture, I have conducted a retrospective study to explore the risk factors for backward bending of IOL in highly myopic eyes. We proved that highly myopic eyes with more severe anterior capsular contraction and lower IOL power implanted are easier to backward bend after cataract surgery. And the design of the implanted IOL in this case is also maybe another contributor. The implanted IOL in this case is designed with modified frame haptics, which has a large gap between the optic and haptics, resulting in less sufficient support from haptics to avoid the force of capsular contraction. Then it is of concave convex shape. Compared with IOL of biconvex shape, under inward extrusion caused by capsular contraction, the biconvex shape can help to resist deformation by diffusing power to both sides. However, the concave convex shape can only deliver the force of extrusion to one side, which is easier to cause bend and deformation. At last, the take-home message is that in highly myopic eyes, postoperative backward bending of IOL caused by capsular contraction probably would lead to an unexpected hyperopic shift after cataract surgery, which would impair the patient's near vision. Thus, when we calculate the IOL power before surgery, we need to take this hyperopic shift into consideration when dealing with such highly myopic patients, especially for patients with low implanted IOL power and a high possibility of a severe capsular contraction after surgery, maybe leaving a more myopia. And it's better to choose IOLs with good capsular support to resist bending deformation caused by capsular contraction. Thanks for your listening.
Good day everyone, I am Dr. Te from the Southern Philippines Medical Center from Davao City, Philippines. I'll be presenting today my case entitled Inside Out. I have no financial disclosures for this presentation. To start, we have a 5-year-old Filipino girl from Lanao del Norte, Philippines, who was referred to our service for leukocoria of the right eye. History started 7 months prior to consult, where the mother noted non-tender swelling of the patient's right arm, which happened after an injury from playing. This persisted on the interim with no consults done. 2 months prior to consult, they noted transient and intermittent eye redness and photophobia. They had also noted progressive swelling of the right arm, hence, 1 month prior to consult, they sought consult for the mass and had an incision biopsy done, revealing a small round cell histologic pattern. There was also an incidental finding of leukocoria of the right eye. They were advised consult at our institution, where they were initially seen by pediatrics and subsequently referred to our service. For the past medical history, aside from the incision biopsy done, she had no other comorbids. Likewise, her past ocular history, family history, and maternal history were also unremarkable. She had only complained of limited range of motion on the right arm, which was consistent with her PE finding of a distal humerus mass. There were no palpable lymph nodes or masses noted. Now, given this information so far, which is the most likely impression? Now, at this point, it might seem a bit overwhelming, but if we take a look at the next few slides, we might be able to narrow down these options even more. For our ophthalmologic exam, the patient had a poor VA in the right eye with high pressures and a fixed dilated pupil. We had also noted a reverse RAPD on the left eye. Focusing on the right, we had noted injected conjunctiva with prominent vessels, a band keratopathy, extropion UVA, and a membranous cataract. The left eye was unremarkable. There was no view of the posterior segment on the right, while on the left, there were no masses seen, and there were also unremarkable findings. At this point, we had decided to go through with some imaging. We had requested for a cranial and orbital CT scan, which revealed a heterogeneous intraocular lesion with an ill-defined calcific focus, as shown here. There was also no intracranial involvement. We had also performed a B scan, showing an ill-defined hyperechoic lesion in the vitreous, and a hyperechoic focus exhibiting high spikes as pointed by the arrows. Given these, we had decided to further intervene by doing an enucleation, from which we were able to yield an 11 mm optic nerve stump with no scleral involvement. On histopathologic studies, we were able to appreciate these findings as pointed on the left by the red arrows, and on the right, as encircled here, we can see retrolaminar involvement of the optic nerve with no optic nerve invasion at the cut end. And below it, we can see, as pointed by the green arrow, massive involvement of the choroid with no involvement of the sclera. Now for the next question, what are these lesions pointed by the red arrows probably called? These are called Flexner-Wintersteiner rosettes. Now going back to the right arm mass, we did an MRI showing a well-defined encapsulated bone mass at the distal humerus on the right. Further studies done with a tissue block using IHC showed negative staining for all of these except for the CD99. Now for the next question, what other neoplastic condition is often associated with CD99 positivity? The answer is Ewing sarcoma. However, despite these findings, we proceeded to request for further stains just to really make sure. Now with these new results, we found positivity with CRX, which is a protein expressed in retinal cells and photoreceptors, and a negative PRB stain, which indicates loss of expression of PRB. Further management of the right arm consisted of systemic chemotherapy and EBRT, which showed interval decrease of the right arm mass, as encircled here on the second photo. Now, going back to the first question, the most probable answer here now would be a primary intraocular malignancy, specifically retinoblastoma. Now, retinoblastoma, as we all know, is the most common intraocular malignancy. It most often presents as leukocoria, strabismus, or periorbital swelling. Regarding metastatic retinoblastoma in general, literature would describe this to be most associated with optic nerve involvement, extrascleral involvement, or both upon presentation. Optic nerve involvement is most associated with likelihood of CNS spread, likewise extrascleral invasion for distant metastasis. We should also not forget other high-risk features which also increase risk. On to the next question. Which of the following are metastatic patterns of RB? Of course, the answer here is all of the above. Distant metastasis to the bone is relatively rare and would often present as swelling. Most documented cases so far occur years post-enucleation or treatment. Now, in this case, we had the presence of high-risk factors. However, it is unusual in the sense that the bone mass was the presenting symptom, there was no extrascleral invasion, and no optic nerve invasion at the cut end. Histopathology was similar to bone masses at this age, which posed a diagnostic dilemma. Now for my last question, which is true about metastasis of RB to the bone? Now the answer here is all of the above. This brings us to our final diagnosis of retinoblastoma in the right eye, stage 4A with bone metastasis. Now before I end this presentation, I would just like to share some few takeaway points. Distant mets to the bone is certainly possible even in a seemingly intraocular RB. These lesions can often appear to be similar to other bone malignancies, especially in the pediatric age group. Next, immunohistochemical stains can certainly help in clinching the diagnosis in these cases. And this would certainly help us in proper identification, hence initiating proper treatment for these cases. Now, that ends my presentation. Thank you all for listening.
Hello everyone, I am Xingye from Zhejiang Provincial People's Hospital, and it's a great honor to be here to deliver this presentation. The topic I will be sharing with you is a case of vitreous opacity in child. This is an 8-year-old boy who came to our hospital because of blurred vision in the right eye. The visual acuity was 0.2 and the intraocular pressure was 9.4. We observed the vitreous opacity and cord-like changes in the vitreous body, and we recommend further examination. The OCT indicated that proliferative memory retraction was causing the elevation of the retina. The patient's left eye showed no abnormal findings. We conducted a retinal angiography for the patient. In the early stage, we observed a lesion with fluorescence leakage around the fovea of the macula. In the late stage, there was fluorescence leakage from choroidal vessels, along with evident peripheral choroidal leakage and vitreous opacity. And peripheral blood tests did not reveal any specific changes. So based on the above examinations, we recommended further tests, but unfortunately, the patient did not follow up. 1 year later, he returned because the vision in his right eye was failing again. This time, he had developed a cataract in his right eye. Interestingly, we did not observe any obvious inflammatory reaction in the anterior segment. During our conversation, we learned that he had received long-term systemic and local steroid hormone therapy at other hospitals during the year. However, the vitreous opacity had worsened. We then performed ultrasound. So is this retinal detachment or the posterior vitreous cortex? We considered several possible diagnoses, including bacterial, lymphoma, virus, fungus, Toxocara, and Toxoplasma gondii. Now the question arose, should we proceed with surgery for this patient? The patient had developed retinal detachment and cataract, resulting in a significant decline in vision and the severe features opposite body, aligning with the indications for PPV. Therefore, we performed the PPV on the patient. Based on a review of the literature, the indications for the diagnostic PPV primarily included the following points: intermediate, posterior or total uveitis. Auxiliary examinations were unable to make a definite diagnosis. Medication treatment was ineffective. Infectious disease or neoplastic masculine syndrome could not be ruled out. So for this child with unexplained features opacity, we proceeded with PPV, and we tested samples of vitreous fluids for pathogens. We removed the opaque vitreous body. It turned out that the condition inside the eye was more severe than we thought. We captured some intraoperative screenshots, which revealed visible proliferation in the anterior vitreous body. A proliferative membrane was observed at the optic disc, causing traction on the retina and form a fold. Peripheral retinal proliferation was severe, and peripheral retinal detachment with anterior proliferative vitreoretinopathy was observed inferiorly and temporally. We also removed the anterior proliferative membrane overlying the retina. For the complicated cataract, we resected the lens and preserved the anterior capsule. Retinotomy was performed, where the peripheral retina was cut to the oral strata and the retinal fold was open. Vitreous fluid testing revealed a significant increase in IgG against Toxocara in the ocular fluid and serum. The GWC was larger than 4, confirming the diagnosis of ocular Toxocara. Additionally, the patient showed significantly elevated levels of inflammatory factors, including IL-6, 8, and 10, indicating severe intraocular inflammation. Routine anti-inflammatory treatment was administered. On the first day after surgery, the retina is flat and the patient exhibited a mild inflammatory response. OCT showed that the retina was flat following the removal of the proliferative membrane. 2 months after surgery, the retina remained flat and the BCVA had improved to 0.2. The fibrosis of the capsular membrane of the lens was apparent. 3 months after surgery, BCVA had improved to 0.5. OCT showed that the macular range of the retina had returned to its normal shape. We could observe the mechanized projection of the bag in the fundus. Treatment included capsule separation and intraocular lens implantation. After surgery, there was successful retinal repositioning and improved visual acuity. However, the angiography still showed evidence of inflammation. Should systematic steroid treatment still be considered? And no apparent abnormalities were observed in the FFA or ICGA of the left eye. So, for underdiagnosed uveitis, PPV or not, this case represents chronic Toxocara endophthalmitis characterized by leukoria, peripheral exudation, and vitreoretinal traction bands. Ultrasonography shows a vitreoretinal traction band. A pathological specimen shows an inflammatory mass and total retinal detachment. For uveitis, PPV has diagnostic value and therapeutic value. and we reviewed retrospective analysis and found that diagnostic gold standard for infectious diseases involved intraocular fluid testing for pathogen-specific testing, and among them, toxocara accounted for about 5%. We reviewed PPV for tractional RD caused by OT. For OT with severe intraocular complications despite medical treatment, PPV can effectively control intraocular inflammation and avoid systematic adverse effects associated with long-term corticosteroid use. By removing proliferative membranes and relieving retinal traction, PPV helps prevent intraoperative and postoperative complications, leading to satisfactory anatomical and visual outcomes. Finally, the following are the main indications and risks of PPV. The indications include obtaining diagnostic specimens, clearing inflammation in apostates, and managing complications. Risks included aggravations of inflammatory response, inducing new complications and intraocular fillings. So, there are still more challenges ahead. That's all. Thank you for listening.
Hello everyone, I am Dr. Paiman Ye. I am from Second Affiliated Hospital of Zhejiang University of China. Today I want to present a case of white vessels. There are no financial conflicts of interest. This is a 32-year-old Chinese woman. She came to my clinic for routine examination. She is a high myopia patient and had CM disease in left eye 3 years ago. She had received intravitreal injection of anti-VEGF. She also had diabetes and is overweight. This time she wants to have a baby and wants to do the fundus examination. Because of the previous disease, the BCVA is not very well. The BCVA is 0.4 in right eye and 0.1 in left eye, but it is as same as last 3 years. The slit lamp examination shows the anterior segment seems alright. She received fundus examination after pupil dilation. The wide field color fundus photography showed that she had typical high myopia fundus and a CMV scar in left macula, but it's notable that she had white vessels in her retina. That is completely different from previous examination. If we use OCT to scan these special vessels, we can find some hyperrefractive dots in inner retina, which corresponds to these vessels. So what's your first impression of these white vessels? What's your primary diagnosis? Usually we will think what can cause white vessels. First of all, the most frequent cause is vessel occlusion, including artery, vein, or both. Some disease can lead to this, like CRAO, and CRVO, ocular ischemia syndrome, and systemic disease-related ocular manifestations like hypertension, diabetes, leukemia, radiation, and so on. Secondly, the cause may be inflammatory cells infiltration, like retinal vasculitis, ear disease, prostate dendritic vasculitis, and some other very rare reasons. There may be some white or creamy materials sustained in these vessels that cause the white vessels. In order to differentiate this possible diagnosis, we do further examination. From this wide field OCTA with 20 by 24 scan, there are no significant non-perfusion area in these images. Also, we do the wide field FFA. The wide field FFA of this patient shows the blood flow seems alright with no occlusion, and there is no fluorescent leakage in these vessels. From these examinations, we can exclude the vessel occlusion disease and inflammatory disease. So we have to do further laboratory examinations to check if there is any other abnormalities. The blood routine is with normal range, but there is amazing findings in blood biochemistry. The level of glucose is slightly higher than normal range. The level of cholesterol is 22.9, and this is significantly higher than the normal range. The level of triglyceride is extremely high, almost 50 times compared with normal range. So, from these findings, we can draw the conclusion the diagnosis of this patient is lipemia retinalis and hyperlipidemia. This is a paper published in 1970 in Jiao. From this paper, we can see the lipemia retinalis can divide it into 3 stages. The first stage is the creamy vessels or peripheral fundus vessels, and the second stage is characterized by creamy vessels extending toward the optic disc. The third stage is characterized by all the creamy vessels in all retina. So this patient should belong to the stage 3. So she went to endocrine department and received lipid-lowering treatment, that is oral statin treatment for 2 weeks. Let's see what can happen to this patient after 2 weeks treatment. All her retinal vessels turned red again. She can be happy to continue her pregnant plan. However, she should check her blood lipid level at regular intervals. And this is her wide field OCTA, and this seems the blood flow seems alright. Thank you very much for your interest and attention at this case.
Thank you very much for all these presentations. We have a few questions on chat. And before I give the floor to our co-moderators, maybe I'll read the first one that refers to the first lecture, first case report. How about using more rigid IOLs and bigger in size? In such eyes, anterior segment is bigger than in less myopic eyes. This is the question to Dr. Jiang Ji, and I would also like to add a question: do you consider any amount of myopia as more risky for development of such complication as shift of the intraocular lens?
Okay, thank you. Yes, indeed, in the clinic, we find this phenomenon, the hyperopic shifts has the highly myopic patients has the hyperopic shift at the long-term period after cataract surgery is not very hard to see. The amount of patients is not very small. So I according to this case, I conducted the study to find the risk factors for this complication for cataract surgery in highly myopic patients. So maybe it's because for the highly myopic eyes, the actual lens is too long. So the implanted IOL, the thickness of the implanted IOL is much thin. So it's easier to have the deformation. So because I think in the future, when we deal with these patients, we can perhaps we should have more myopic, target more myopic, so let them can have a good near vision after surgery. Yeah, thank you.
Yeah, maybe consider the axial length that borders the name exactly, the amount of axial length that would create this risk. That would be interesting, I think, to directly point out a certain number. Moderators, do you have any questions for Doctor? This?
Yes, actually, my question would also go into the same direction. We have recently learned that in cases of pseudo-exfoliation, we were recommended to have a larger capsulotomy so that the shrinkage would be less, and then maybe there would be less stress on the sonula. And so my question would be, is the size of the capsulotomy somehow important in this backward shift?
What's the backward shift?
So if you have a larger capsulotomy, do you also notice that there is a shift in this IOL?
Yes.
Could you prevent this because the shrinkage is less if the capsulotomy is larger?
Yes. Because actually we want to. In our study, we want to search the lens position at 1 week after surgery, so we can compare the shift in the lens position. But the UBM is an examination for patients. It's a little dangerous. In 1 week after surgery, maybe it can cause infection. So we didn't have the data at the 1 week.
Mm-hmm. Okay, thank you very much. I think we have to move to another lecture. I have one question on chat to Dr. Vincent about the rationale behind the enucleation at this point in this girl. Didn't you consider any other options rather than such a drastic approach?
Hi, good evening. Since we're highly considering retinoblastoma at that point, we thought we had to do an enucleation since it was filling the entire globe. In the local setting, although we don't have any other options available, since the treatment, for example, for other forms of chemotherapy are very expensive. So here, we most of the time we do resort to doing an enucleation. Okay. Hence the operation.
Okay, thank you. Co-moderators, any questions to that case?
No.
Okay, so let's move to the third one. Dr. Ksenia, do you have any comments maybe to this interesting case, toxocorosis, and the, let's say, diagnostic vitrectomy? Have you tried, maybe I have a question, have you tried vitreal sampling before deciding about the surgery? That would be interesting to do some immunological workup for the vitreous. I'm not sure whether Dr.
Well, if I recall correctly from the case presentation, the retina was already detached by the time they scheduled the surgery. So,
Yeah.
you know, with an attached retina that you just want to get the sampling,
Yeah.
right? You can see an argument to just sample some vitreous, but once you're committed to repairing the retinal detachment, you might as well get as much material as you can.
Okay.
Yeah.
Okay, so the fourth case report by Dr. Jiang, the interesting case, well, similar to frosted arthritis. Are there any questions to that one? Or
Yes,
comments?
I have a question. I thought terrific case, beautiful images. Once you had the wide field OCT angiography showing intact perfusion in all quadrants, was it necessary to do the fluorescein angiogram, or did you have enough information to make the diagnosis?
Mm-hmm. Okay.
Yeah. So I would I have a question, because I think that these were really amazing images. So where exactly are the lipids located? Is that known, or do we have the speaker here live, or?
So Jiang, are you with us?
No. So okay, then I
withdraw
the question.
I wonder whether there is a certain amount of cholesterol or lipids that
well, in theory, they would probably have to be in the wall.
In the wall, right? Yeah.
Yeah.
Yeah, that's what I would assume.
The outer surface of the vessels, right?
Yeah.
Okay.
But I thought that the concordance, right, that the OCTA matched the fluorescein angiogram very well, which right, I've been thinking for a long time, if you can get a high quality OCT angiogram in a retinal vascular disease patient, you might not need to do the fluorescein angiogram.
Absolutely. Yeah. Yeah. Good point.
Okay, thank you very much for all this comment. Let's move to the second part of this session, please.
Dear colleagues, today I want to present you a few cases of complication of Ozurdex use. I have no conflict of interest. Ozurdex is an implant which contains 700 milligrams of dexamethasone and approved to treat diabetic macular edema in case of retinal vein occlusion and non-infection uveitis, which affects of posterior eye segment. Possible list of complication. Case 1 demonstrators 42 years old male patient with persistent macular edema after treatment for choroidal melanoma with radiotherapy, transscleral resection, multiple vitrectomies, previous treatment with triamcinolone injection and anti-VEGF injections wasn't effective, and we discussed with him pros and cons of Ozurdex use, and this Ozurdex use was recommended in previous clinic, and we've done this uncomplicated. For therapy, his OCT was massive macular edema with disorganization of layer with loss of some retinal cells. Patient comes immediately, emergency to us because he couldn't see implant anymore, and before he still could see an implant, and the patient was instructed from us, if he will not see implant anymore, he should come immediately, and it was the case. And in intelligence we could see Ozurdex implant, and in this patient we've done next day surgical removing of Ozurdex, and corneal still stay clear. Even 4 months later, cornea still stay clear, and such case demonstrates that if patient comes immediately and will be examined and treated, it will prevent for further corneal surgery. In other cases, it comes to decompensation of cornea, and patient needs to get a corneal surgery. Case 2 demonstrators. Next, 42 years old male patient with persistent macular edema after retinal detachment. He got Ozurdex, and visual acuity was increased, and he comes to routine follow-up examination, and we could see Ozurdex implant located between iris and intraocular lens, and it was a picture from slit lamp, and we could see that Ozurdex implant was quite movable following the head position, and we have instructed the patient to tilt his head to the side, and a few minutes later Ozurdex was moved back in the vitreous, and in further weeks and months, Ozurdex was resolved in normal way, and the patient don't have any other complications. And this case demonstrated as other possible way of dislocation of Ozurdex in the anterior chamber, because mostly Ozurdex dislocated in case of iris defects. Third case demonstrates as 81 years old women with diabetic macular edema, and he was treated with multiple anti-VEGF injections, and on the right eyes this injections wasn't effective anymore, and we tried to treat her with Ozurdex, and the procedure was with some complication. Patient had head movement, and in our clinic we examined every patient immediately after Ozurdex injection, and we could see that Ozurdex was inserted in a sclera, and with a 30 gauge needle we've pushed Ozurdex deeper inside in the vitreous, and we have done some massage of this point, injection area, which typically for vitreoretinal surgery after removing of trocars, and OCT immediately after Ozurdex injection showed us opening in sclera, and some part of vitreous inserted in sclera channel. But on next day we can see that sclera is closed, and eye pressure was normal, and 3 months later sclera was closed, eye pressure was normal, and visual acuity was increased in a nicely way. All this case have important take-home messages. First of all patients which are treated with Ozurdex injection should be educated to be aware of symptoms of Ozurdex dislocation, and such patient should be examined immediately, in best case the same day. Second case demonstrates as possible other pathway of Ozurdex dislocation, and sometimes it's enough just simply head tilt movement, and don't need any surgery. And third case demonstrators, first of all, Ozurdex injection should be performed by experienced ophthalmologist. Patient should be good instructed to keep calm and don't move his head, and we recommend to regulate the eye and Ozurdex position immediately after performing the injection of Ozurdex. Eye pressure, corneal corneal and to check if Osidex is in vitreous, and in some cases it's not necessary to do corneal scleral suture because corneal sclera will be closed in the next day. Thank you for your attention. I'm happy to answer questions.
Dzień dobry Państwu. Dziękuję za zaproszenie do udziału w sesji. Chciałabym przedstawić Państwu kilka krótkich przypadków zastosowania nowego leku antyangiogennego farycymabu. Najpierw jednak przypomnę kilka informacji związanych z tym preparatem. Zaburzona produkcja czynników wazoproliferacyjnych jest przyczyną rozwoju naczyń neowaskularnych w wysięgowym AMD lub w proliferacyjnej retinopatii cukrzycowej, a także obrzęku siatkówki w wielu chorobach, m.in. w AMD, cukrzycy czy pozakrzepach żylnych. Dotychczas uważano, że podstawowym czynnikiem, który sprzyja tym zaburzeniom, jest VEGF, czyli czynnik wzrostu śródłąka naczyń. Od kilkunastu lat dostępne są leki anty-VEGF, które w miarę skutecznie działają w wymienionych chorobach. Do tych leków należą ranibizumab, aflibercept, brolucizumab oraz stosowany off-label bevacizumab. Nie do końca nas satysfakcjonuje skuteczność tych leków i nowa wiedza na temat złożoności procesu angiogenezy i obrzęku siatkówki zmobilizowały do dalszych badań i w efekcie powstała nowa cząsteczka lecznicza. Jest nią zarejestrowany w 2022 roku farycymab, który działa zarówno przeciw VEGF, jak i przeciw angiopoetynie typu 2. Farycymab jest w pewnym sensie hybrydą, gdyż w jednej wspólnej cząsteczce łączy dwa przeciwciała, przeciw VEGF oraz przeciw angiopoetynie typu 2. Angiopoetyna ma bardzo istotne znaczenie w promowaniu powstawania patologicznych naczyń zarówno bezpośrednio, jak i zwiększając produkcję VEGF. Nowy lek ma więc dwa równoległe punkty uchwytu, co zwiększa jego potencjał. Badania kliniczne wykazały, że farycymab u znaczącej liczby pacjentów w fazie podtrzymującej może być stosowany w długich interwałach. U około 80% pacjentów co 3 miesiące, a u około 60% pacjentów co 4 miesiące. Farycymab ma też udowodniony wysoki profil bezpieczeństwa. Chociaż lek jest nowy, to jest chętnie stosowany zarówno u pacjentów dotąd nieleczonych, jak i u tych, u których skuteczność innych leków jest niewystarczająca. Do tej pory sprzedano ponad 1 milion fiolek farycymabu, zarejestrowano go w 81 krajach, a objęto refundacją w 25. Lek jest zarejestrowany do leczenia wysięgowej postaci AMD oraz cukrzycowego obrzęku plamki. Farycymab różni się od innych leków dłuższą fazą nasycającą. W przypadku AMD są to 4, a nie 3 dawki. W fazie podtrzymującej kluczowe są wyniki badania w 21 oraz 25 tygodniu. Stwierdzenie aktywności w 21 tygodniu powoduje, że część pacjentów musi otrzymywać lek co 2 miesiące. Natomiast brak aktywności pozwala wydłużyć odstępy do 3 miesięcy, a w przypadku braku aktywności również w 25 tygodniu do 4 miesięcy. Decyzje w fazie podtrzymującej, podobnie jak w przypadku innych leków, bazują przede wszystkim na wynikach badań OCT, oczywiście w powiązaniu z obserwacją ostrości wzroku oraz obrazu dna oka. Ja osobiście w przypadku leczenia pacjentów z AMD każdym z dostępnych leków obok OCT posiłkuję się obserwacją aktywności naczyń patologicznych w angiografii OCT. Zastosowanie farycymabów w cukrzycowym obrzęku plamki również może się wiązać z zastosowaniem większej liczby dawek, chociaż faza nasycająca jest akurat identyczna jak dla AMD, czyli 4 dawki co 4 tygodnie. Różnica pojawia się w fazie podtrzymującej. Zawsze należy podać pierwszą dawkę podtrzymującą po 2 miesiącach, nawet przy braku cech obrzęku siatkówki podczas kontroli w 21 tygodniu. Analogicznie druga dawka podtrzymująca, czyli w sumie 5. dawka leku, musi być podana nie później niż po 3 miesiącach od poprzedniej. Następne interwały mogą już wynosić do 4 miesięcy. W przypadku obrzęku cukrzycowego plamki, podobnie jak w AMD, podstawa naszych decyzji to badanie OCT, ale oczywiście również w powiązaniu z badaniem ostrości wzroku. Przechodzimy do quizu. Pierwszy przypadek. 70-letni mężczyzna leczony z powodu wysięgowego AMD afliberceptem z dosyć mizernym efektem. Ostrość wzroku 0,25, a grubość centralnej siatkówki 406 mikrometrów. Po podaniu 3 dawek farycymabu doszło do poprawy widzenia do 0,4, a grubość siatkówki zmniejszyła się do 333 mikrometrów. Pytanie moje jest takie, czy podać 4. dawkę nasycającą farycymabu. Kolejny przypadek. 62-letnia kobieta z cukrzycowym obrzękiem plamki, również wcześniej leczona afliberceptem. Przed włączeniem farycymabu ostrość wzroku wynosiła 0,3, a grubość siatkówki 570 mikrometrów. Po podaniu 3 dawek nasycających ostrość wzroku 0,5, a grubość siatkówki zmniejszyła się do 359 mikrometrów. Pytanie jest podobne, czy podać 4. dawkę nasycającą farycymabu. I ostatni przypadek, trzeci. 80-letni mężczyzna z wysięgowym AMD od 7 lat, leczony dotychczas afliberceptem, okresowo z bardzo dobrym efektem. W 2022 roku miał pełną ostrość wzroku, zanik naczyń patologicznych, co spowodowało przerwę w leczeniu. Niestety na początku 2023 roku doszło do wznowy aktywności CNV i spadku widzenia do 0,6. Rozpoczęto podawanie farycymabu. Po 3 dawkach doszło do regresji naczyń i ostrość wzroku poprawiła się do 0,8. Pacjent otrzymał w sumie 5, a nie 4 dawki nasycające co miesiąc. Leczony był za wielką wodą, nie u nas w Polsce, tylko w Stanach Zjednoczonych i następnie po 2 miesiącach dostał 1 dawkę podtrzymującą. Podczas kontroli po 2 miesiącach ostrość wzroku jest nadal stabilna, ale w angiografii OCT jest obecna aktywność naczyń neowaskularnych większa niż na początku. I pytanie moje jest takie, czy podać kolejną dawkę farycymabu. Na razie dziękuję Państwu za uwagę. Ciekawa jestem, jakie są Państwa propozycje odpowiedzi. Natomiast przeźrocze z moimi sugestiami na razie pozostaje tajemnicą.
Hello everyone, my name is Magdalena. I am ophthalmologist and I work in ophthalmology clinic in Kielce in Poland. Today I want to present you some interesting case study. I examined a young woman in the age of 37 years in December of 2020 with reduced visual acuity of the right eye to the level of 0.1 and with normal visual acuity of the left eye. In these pictures we can observe in the figure 1 the fundus of the right eye with mud reflex and changes in pigmentation in the macula. In the figure 2 we can observe the normal appearance of the fundus of the left eye. The next pictures show the image of fluorescein angiography. In the figure 3 we can observe early phase of fluorescein angiography with slight hyperfluorescence in the macula. In the figure 4 we can observe the late phase of fluorescein angiography in the same right eye with hyperfluorescence increasing with time. The next slide shows the image of autofluorescence in the right eye. The next slide presents the normal appearance of the fundus in the left eye during the fluorescein angiography examination. The next picture shows the image of swept source OCT triton with increased thickness of the choroid in the right eye in the vertical scan. The next slide presents the image of swept source OCT triton with convex elevation of the RPE, retinal pigment epithelium, the retina and choroid in the right eye during vertical scan examination. The next slide shows the image of swept source OCT triton in the right eye with the increased thickness of the choroid. The next picture shows the OCTA image, optical coherence tomography angiography in the right eye without choroidal neovascularization, CNV, in horizontal scan. And the last picture shows the image of scan B in ultrasonography examination with hyperrefractiveness. So, do you know what's the problem? What's the diagnosis of this disorder? What do you think? So, I can tell you about this disorder in the next slide. This is dome-shaped macula. This disorder was first described in 2008 by Gaucher. The diagnosis is based on swept source OCT. We can observe here convex elevation of the retinal pigment epithelium, the retina and the choroid in the posterior pole of the eyeball with the lesion height above 50 micrometers above the line joining the RPE on either side of the DSM in vertical or horizontal scans. It occurs predominantly in myopia but also in ametropia and hyperopia. There is no association with gender. The lesion is diagnosed most often in the 4th and 5th decade of life. Bilateral occurs in 30 to 80%. It's diagnosed in adults, children, and adolescents. The pathogenesis of DSM is controversial. We can consider congenital predisposition, a rupture of Bragg's membrane at the border of elevation of structures within the posterior pole, choroidal thickening within the lesion, while thin choroid outside the lesion. It's a localized thickening of the sclera within the lesion with subsequent disruption of choroidal outflow. We can consider also mechanical RPE dysfunction. What about the symptoms? The diagnosis may be accidental without symptoms. Symptoms occur in case of complications, for example, CNV, serous macular detachment. We can observe here a decrease in visual acuity for distance and near metamorphopsia and central scotoma. During fundus examination, we can observe mud reflex, changes in retinal pigmentation, intraretinal or preretinal hemorrhages if CNV coexists, thin retina, paler nerve optic disc due to myopia. We can differentiate DSM from myopia with posterior staphyloma, tilt disc syndrome, posterior pole tumors, and choroidal neovascularization during exudative form of AMD, central serous chororetinopathy, or myopia. There's no clear defined treatment of DSM. We can administer intravitreal anti-VEGF injections if CNV coexists, laser photocoagulation, topical carbonic R-hundrase inhibitors, and mineralocorticosteroid receptor antagonists. And conclusions: swept source OCT and OCTA are useful tools in diagnosing the disorders of the posterior pole of the globe. These examinations help in the differentiation of dome-shaped macula from other disorders, especially with CNV, like exudative form of AMD, myopia, or SCR. Patients treated due to DSM can be monitored with swept source OCT and OCTA. Thank you for your attention. Bye.
Hello everybody. Today I would like to present a case of severe bilateral visual loss in case of short-term central serous chorioretinopathy. Here are my financial disclosures. Central serous chorioretinopathy has been well described in the literature. However, we know that its pathogenesis is not clearly understood. We know that it's usually short-term and self-limiting disease. It affects definitely more often males with the proportion to females at 2.6 to 1. And we also know that it occurs in younger patients. However, this age is a little bit higher than we previously thought. It's usually between 40 and 50 years old. We know that there are some chronic cases, long-standing cases that present finally with significant visual loss, and this is our very much concern according to available treatment options. We also know that this disease can be complicated by macular neovascularization, that this is up to 40% of patients that are reported with this complication. Here I present modern classifications and, in fact, diagnostic criteria of CSTR. The hallmark of the disease is subretinal fluid, but we also have to consider alterations of the RPE, leakage on fluorescein angiography, and nowadays also increased subovaral choroidal thickness, as CSTR is considered a disease from the spectrum of pachychoroid diseases. There are different forms of classification of central serous, starting from the traditional one, when we used to divide CSTR into acute and chronic cases, depending on the durations of the disease, with the division somewhere between 4 and 6 months. However, nowadays we rather use the multimodal imaging-based classifications published by the CSTR group in 2020, and this is division into simple and complex cases depending on the areas of RPE anomalies observed on the fundus autofluorescence. Italian colleagues also proposed the RPE type and choroidal type in CSTR. This referred to acute cases. My Italian colleagues, they think that choroidal type, these are patients with very, very high choroidal thickness of more than 450 micrometers, and RP type, these are the patients that in whom we observe the alterations at the RPE signal on the OCT from the beginning of the disease, even in the acute stage. We have different therapeutic options. I have listed them. We used to wait for the spontaneous resolution of symptoms, as the only therapeutic option was laser photocoagulation that resulted in retinal scar at the end. So observation was advocated for 3 to 4 months. However, nowadays, as we have subthreshold, non-damaging retinal lasers, we rather tend to treat early or without any delay. We know that photodynamic therapy works well in both acute and chronic cases, but we also know that Visugen is not available at the moment, so we have a problem. Mineralocorticoid inhibitors, especially eplerenone, is also used, but from the meta-analysis published, we know that it works only in selected cases. It does not work for the whole cohort of patients. Now, I would like to present a case of a 37-year-old active soldier who obviously had perfect vision, as he served abroad in military missions, and he presented with central ceros in both eyes, however, not at the same time. I treated the right eye, but before he came to my center, he experienced the episode of CSTR in his left eye that was treated with classic laser photocoagulations after observation time of 4 to 5 months. The procedure proved successful. However, his final visual acuity was 0.1, which in fact was a very significant impairment. When I treated him immediately, as he presented with subretinal fluid on SOCT. He also presented with significantly increased suboval choroidal thickness, which was about 700. And I treated him with subthreshold micropulse laser, both yellow 577 and infrared 810, but without any prominent effect. So I tried to organize the Visudyne vial for him, and I succeeded. I performed PDT, and the symptoms resolved. I mean, the SOCT symptoms resolved, subretinal fluid resolved. However, his final visuality was very poor. It slightly improved with the observation, but it remains at the level of 0.1 on the Snellen chart. So when we considered his binocular vision, it's not more than 0.1 in both eyes. Let's look at his diagnostic procedures. When we look at the fluorescein angiography, it looks very mild. It looks as a benign disorder because there is a single leakage point in each eye, and it's located outside the fovea, so we wouldn't classify him as a complex case. Same with autofluorescence. We see some alterations due to the presence of subretinal fluid in the right eye. However, we do not see any significant loss of the RPE cells. We do not see any spots, plaques of hypoautofluorescence. Here, in the right eye that I treated, we see some alterations at the level of the RPE, which can be referred to the accumulation of lipofuscin, but there is no, again, significant loss of the RPE cells. When we look at his SOCT exams, we see that it was a simple presence of subretinal fluid without, for example, intraretinal abnormalities. We see that at the end of the observation time, the subretinal fluid resolved, but this was after the PDT procedure. His left eye remained stable during my observations, but again it presented with significant retinal thinning and with prominent loss of photoreceptors. I examined his ganglion cells at the end of the study, and we see that in the right eye we see very, very significant loss of the ganglion cells and just a sectoral loss in ganglion cells in the left eye. But in both eyes we see that some of the ganglion cells are lost. And I believe this is the reason for his impairment in vision. What would be the conclusions? The conclusions are that CSTR is a complex entity that we still do not have all the knowledge about. We see that retinal layers loss can occur early in the treatment, in the course of the disease, even in simple cases. I believe that delaying the treatment of CSTR can result in substantial visual loss, and I'm treating my patients at presentations. When they present with subretinal fluid, I usually perform micropulse laser. Nevertheless, the choice of treatment should be based on the modern CSTR classifications, and for example, when we see that we have an RPE that is compromised, we know that these patients would benefit more from the PDT. And here is my proposition of treatment algorithm in CSTR. As I said, we have to divide those patients into simple and complex cases, then start treatment early, preferably with micropulse laser, if we see that this is a complicated, long-standing case, with much probability, PDT will be our treatment of choice. Thank you very much. Thank you very much for your attention.
Good afternoon. Today I will be presenting a retina case that we encountered at Bascom Palmer Eye Institute in Florida. I have no financial interest or relationship to disclose. The case is that of an 80-year-old woman who presented for bilateral geographic atrophy due to age-related macular degeneration. She has a history of macular hole surgery in the right eye in 2014 and an IOP spike to 76 millimeter mercury in the right eye in 2015 with no clear cause as per the record. She was not on steroids, she had no inflammations and no angle closure at that time. In 2021, at her first presentation in our office, her vision was 20/70 in the right eye and 20/80 in the left eye. At the follow-up visit in 2022, the vision was stable in the right eye, but declined to 2100 in the left eye. So she was being followed up regularly with color fundus photos and OCT with near-infrared images. The 2023 visit showed that the best corrected visual acuity was 20/80 in the right eye and dropped to 21/50 in the left eye. However, at pinhole, she goes up to 28. Her pressure was 18 in the right eye and 20 in the left eye. OCT RNFL showed thinning in the right eye but normal RNFL on the left, and she was using timolol twice a day only in the right eye. Her past medical history included diabetes mellitus, hypothyroidism, and systemic hypertension, all controlled with systemic medical treatment. So at the 2023 visit, the fundus photos on the right and on the left eye are shown here, showing the geographic atrophy centrally with extensive drusen. On the OCT on the right eye, we see that there is an irregular inner retinal contour due to prior macular surgery. There is foveal thinning and the geographic atrophy. And on the left eye, we clearly see the geographic atrophy with central drusenoid changes. The fundus autofluorescence shows hypoautofluorescence in both eyes centrally, corresponding to the geographic atrophy. So at that time, the pegcetacop plan was approved by the FDA. So it was offered to the patient. We made sure that she had no macular neovascularization on the OCT and the OCTA. Informed consent was obtained, and the decision was to initiate treatment in the left eye, which was the worst seeing eye. So after the injection, on day 10, the patient notes visual disturbance in the left eye, noted as purple iridescent wave. However, she did not consult and she did not report this finding at that time. Day 18 after the injection, she had pain in the left eye and she consulted the optometrist, which recorded a best corrected visual acuity of 21/50 without improvement, a pressure in the left eye at 30 millimeters mercury, and this photo was taken at the time of presentation with a mild conjunctival injection and mid-dilated pupil. So at that time, the optometrist decided to give her timolol also in the left eye. She was intolerant to other glaucoma drops and to follow with us in a few days. Day 23 after the injection, she presents to our clinic with the best corrected visual acuity of 21/50. On slit lamp exam, we found 1+ AC cells in the left eye with conjunctival injection, and her pressure was persistently high in the left eye at 31 millimeters mercury. So we decided to do some fundus photos and compare them to the prior fundus photos before the injection, which is seen in the subset here, the smaller photo. So what we see is posterior pole and mid-peripheral retinal hemorrhages. We also saw arterial attenuation, irregular venous caliper, and segmentation, as well as focal areas of retinal whitening. We did a fluorescein angiography at that time, and this shows at minute 216 the occlusion of the arteries and the venules affecting all 4 quadrants, including the macula. The macula is affected within the 5 degrees of the foveal center, And there were some dilated large venules with stippled hyperfluorescence. The optic disc was staining as well, and there was some leakage. So given the findings of decreased visual acuity in the left eye after the injection, the pain, the increased pressure, the iritis, the vascular occlusion, and the optic disc staining, we wanted to know what this fits, which big picture does this fit? It was actually occlusive vasculitis. So we started her on prednisolone drops every 2 hours with tapering, and we ordered a vasculitis and neuroretinitis laboratory panel to make sure that we are not missing an infectious or an inflammatory cause. The syphilis, tuberculosis, Lyme disease, Bartonella, toxoplasmosis, TMV, lupus, AIDS, homocysteine, ANCA, the CRP, among others, came back all negative. So at day 27, when we saw her in clinic with those lab results and a good pressure, we decided to do a steroid injection in the form of dexamethasone implant to control the vasculitis. We put her on treatment of prednisolone twice a day in the left eye, as well as timolol in both eyes, and we saw her after 4 weeks. 4 weeks later, her best-corrected visual acuity in the left eye was 2200, and her eye pressure was 17. There was no iritis, however, there were some vitreous cells with mild haze in front of the optic nerve. On the photo here, we see that there were some minimal changes in the vascular appearance, not much of an improvement. We have narrowing of the vessels. We still have the intraretinal hemorrhage, which are persistent. And on the OCT, we see that the inner retinal layers were thickened as compared to the prior OCT before the injection. So given the initial non-response to steroids, the decision was to observe and follow up every 4 weeks. So a temporary association of retinal vascular occlusion after intravitreal injection of pegcetacoplan in this patient raises concerns for a drug-related or injection-related toxicity. More than 100,000 vials were distributed up until now, with less than 0.01% risk of occlusive retinal vasculitis in the real world. Cases confirmed both by the drug company and the ASRS REST committee showed that there were 7 occlusive cases, 3 non-occlusive, and 2 suspected events. Structural variations in the specific 19-gauge splinter needle was thought to be the cause. So it was discontinued, and the use of 18-gauge needle was recommended. So we recommend that physicians using pegcetacoplan to treat patients with geographic atrophy should specifically include discussion of the occlusive vasculitis risk in the informed consent and process, and to remain vigilant for similar findings. I would like to thank the Bascom Palmer Eye Institute, the imaging department, Dr. Davis and Dr. Schwartz for their expertise, and the case reports in ophthalmology for having me. Thank you.
Okay, thank you very much for all these presentations. We do not have all the speakers with us, but we have Dr. Dmitrii, who presented the first case, the complications of Ozurdex. So are there any questions to Dr. Bagautdinov?
Well, maybe not a question, but a comment. We also had one patient with an iris clip lens, and the Ozurdex managed to get, although the pupil was not too wide, managed to get into the anterior chamber. So thank God you found this very early and could remove it without any damage to the cornea. So it really, we really have to be cautious in cases of iris clip lenses, and also Allergan changed their license and specifically excluded those lenses now. So we really have to take care. Nice cases.
Yeah, thank you. If I may to say just a minute, I think it's important that patients should be really good instructed, and if they feel something is different, they should come immediately. And in this case, we can save the cornea, and this is important. We can save we can prevent the need of other corneal surgery. That's why
absolutely.
I think it's an important point. Yeah.
Okay. And I believe also that these patients after vitrectomy are at more risk, right, for traveling of the implant. Also. Okay, so we have with us Dr. Magda Kai, who presented the case with dome-shaped macula. So are there any comments or questions about this, in fact, fascinating disease without any recommendations for treatment so far?
Well, I guess the recommendation for treatment is a good question.
Laser with all success, but a few cases responded.
I think these dome-shaped maculopathies are more often than we actually thought in the past. So it's especially nice to see them on OCT and even on the wider field OCT. They can be really nicely diagnosed.
And I have a question to Dr. Magda. About the choroidal thickness, because from my experience at least, it's not always that we have increased choroidal thickness, because that might lead us, for example, with the PDT application, which really doesn't work in all cases, right? So what do you think about that?
So this is only my one experience. Yes, I observed only one patient with this disorder. Yes, and I observed this woman for 1 year. She has received 3 anti-VEGF injections, and despite this treatment, there's no result when we are performing swept source OCT, and when we examine also visual acuity, far visual acuity. The visual acuity is still on the level of 0.1, so there's no result despite the treatment. So this only my one patient. I have no more patients with this disorder in my observations. So my experience is very low in this subject. Yes, but maybe in the future. Yes, but I think nowadays we can differentiate this disorder using swept source OCT. Yes, we can exclude, for example, intraocular tumor. Yes, because we can observe intraocular tumors in younger adult patients. Yes, so we can differentiate this problem with from pachychoroid disorders. Yes, so we should know about the presence of this disorder and remember about this, and we can confirm this condition with OCT. So I think we should be calm, yes, and we should tell the patient about this disorder and say that nowadays there's no clearly treatment in this disorder still. Maybe in the future.
Thank you very much.
Thank you.
Now, maybe my case, because I see really a lot of central serous. I have about 300 of patients under my care, but it was an amazing case. So do you have any clue why it happened this way?
I have a question. Do you use OCTA in those cases on a regular basis? Yeah, because I think really in CSCR cases, OCTA is absolutely helpful to detect neovascularization. And so it's easy, it's quick, and
Yeah, I do it routinely because we know that the incidence of this membranes is much higher than we previously thought, especially with the use of OCTA.
Yeah.
But I generally, when I see this cohort of my patients, I see that even if you have a spontaneous resolution, or you would see that the result is let's say, morphologically speaking, good. The patients are usually complaining on some, let's say, deficit in the quality of vision. So I think that even a few months of presence of subretinal fluid sometimes affects in deterioration of vision.
Yeah, so what you recommended is that you treat the patient at once, right? Not wait until it. Yeah. Well, we have some German guidelines where we would wait a few weeks to see whether it would resolve on its own or not. But as you say, patients are really bothered by the condition, and these are usually young patients, type A personality, so manager. So sometimes they just don't want to wait, right?
Okay, thank you for that comment. We do not have Dr. Mariana with us, but we have Professor Schwartz from the same center. So maybe I ask you, what do you think about the implication of such additional complication for, let's say, the general use of drugs like that? Because we have the experience with, for example, Beovu, which I think had a similar, immunogenic complication, and it was marginalized. So do you think that it might happen with these new drugs that were really
Actually, it looks like Dr. Abi Karam is with us, so I'm going to let her answer that.
Oh, okay, sorry. Okay, great. Welcome, please.
Hello. Yeah, so I think, it is kind of similar to what was seen with Beovu. However, it's because it's a new medication now, and the reports were like highlighted that this happened. But even though that we're still at only 100,000 vials, which is a good number as a start, the incidence is very, very low. And in the cases that were reported, most of the patients that were reported did get an improved vision. So it wasn't like a lost eye or a lost vision, or they were already at a very low vision and they preserved their baseline vision. So I think that time will tell if we will reach a point where it will be marginalized or not. But it's important because that's the only thing we can offer up until now to the patients. Some things are on the horizon, but that's our only option for now.
I can tell you that there are many retina specialists in the U.S. that don't use complement inhibitor drugs at all, right? We now have two because Avastin Pegol was recently approved also, but you have to remember these drugs don't improve anybody. All these drugs do is slow the decline. You probably have to treat monthly or every other month for the rest of the patient's life to really get any benefits. So just based on the clinical trials data, there are many physicians that won't use these medications at all. And certainly this new complication isn't helping things. Personally, what I've been doing is, and this has been taking me a long time in the last 6 months, but I have a very detailed conversation with every patient. And I tell them, just like we said, nobody gets better, everybody gets worse. It's a lot of injections. It might wake up wet macular degeneration, and there's a very small risk of damage to the blood vessels. And in my personal experience, most patients decline treatment.
Yeah, so if I may ask, Stephen, since you have now 2 FDA-approved drugs, and we in Europe are still waiting for the EMA approval. So how do you decide in your daily patient routine, how do you decide, first of all, which of the 2 drugs would you prefer to take? And I know the FDA approval is really, it's a broad label. So do you treat the better eye, the more progressed eye? So if you treat a patient, which drug and how do you decide?
At my institution right now, we still only have pegcetacoplan available.
Okay.
So the second drug hasn't come in yet. We're anticipating every day. I don't really know the difference. And I think the only way you can know is to try them. I think, it's getting out into the community that the patients are starting to hear about these vasculitis cases. So it might be easier to recommend the alternate drug when that's physically with us. I think that patients with concomitant neovascular disease and geographic atrophy, I think it makes more sense to try to extend the anti-VEGF treatment intervals, because the recommendations have been to only inject one drug per eye per visit. So patients that need monthly anti-VEGF, those probably are not good candidates for complement inhibition. That's why faricimab, and also in the US just got approved aflibercept 8 milligrams, which is called Eylea HD. Right. So hopefully these drugs will allow us to get to 3 or 4 months with patients, and then it's much easier to fit the complement inhibitor drugs in the middle. I think there's like a Goldilocks spot. You want enough geographic atrophy that it's threatening vision. But you don't want so much geographic atrophy that there's not going to be any benefit to treatment. So if you have a very large atrophic lesion and very poor visual acuity, I'm not sure what the complement inhibitors are going to do for those patients.
Thank you very much, because we're running out of time a little bit. So I'd like to thank my co-moderators. I'd like to thank all the lecturers who prepared hardly, who put hard work into preparing of those cases. So thank you very much, and welcome to another session in a few minutes. Thanks.
Thank you.
Thank you.
Hello, everybody. I would like to open the next session, which is titled Ocular Surface New Challenges. I'd like to welcome all participants, and I'd like to thank the organizers, Professor Grzybowski, for inviting me to chairing this session. It's a great honor for me. Let me introduce the speakers. We have 6 cases for this session. The first one is going to be presented by Dr. Hana Vienne from Philippines, from Southern Philippines Medical Center. The second one will be presented by the speaker from China, Wen Wen He, sorry for pronunciation, from Nose and Throat Hospital of Padang University. The next one, the third one, is also from Philippines, the same center, Southern Philippines Medical Center, Dr. Janindu Bilano. The next one, the fourth one, is from Poland, from Pomerania Medical University, Dr. Agnieszka Kuligowska. The fifth one is from Ukraine, National Pirogov Memorial Medical University, Dr. Katerina Chrysmy-Malska. And the last one is from USA, Dr. Alistair Gibbons from Bascom Palmer Eye Institute, University of Miami. Okay, so let's start the session.
Good day, everyone. I'm Hana from the Philippines, and I'm here to present a flip case. I have no financial disclosure. This is a case of FO, a 1-year-old male from Agusan del Sur, Philippines, who came in due to left corneal opacity. History started at birth when the parents noted that the child was different from other babies, with note of averted upper and lower lids on both eyes. However, the parents only opted to observe the child's condition. At 7 months old, they noted left corneal opacity associated with eye redness, pain, and yellow-whitish discharge. Consult was done, and they were given the following medications, which improved the patient's symptoms. They sought another consult wherein they were advised for surgery. However, they were lost to follow-up. They only continued the medical management. However, persistence of the whitish corneal opacity prompted consult. Question: this eyelid malposition, defined as the outward turning of lid margin, is called A. Epiblepharon, B. Entropion, C. Ectropion, or D. Ptosis? Answer is letter C. Ectropion. Patient was born to a 42-year-old Gravida 5 Para 5 mother via non-institutional delivery, with poor Apgar score and note of upward slanting palpebral features. The prenatal and postnatal history were unremarkable. Physical examination showed everted upper and lower lids with scabs on lower medial lid margin as well as crusting. 8 mm distraction test and 0 tag test were noted on both eyes. The right eye was unremarkable. However, on the left, we noted 2 to 3 mm crescent-shaped corneal opacity at the mid-periphery 5 to 7 o'clock with no dye uptake. The rest of the examination were unremarkable. So what are the goals for treatment for this case? What is the management, and when do we do repair? Our goals are to protect the cornea, prevent amblyopia, and improve cosmesis. Management include the conservative management of lubricants and moisture chamber. However, if it does not respond to medical management, we can do surgical intervention, such as tarsorrhaphy with excision of redundant conjunctiva, fornic suture, full-thickness skin graft, full-thickness horizontal lid shortening, or attachment of the orbital septum to the levator aponeurosis. For this case, we did repair of ectropion with extensive blepharoplasty suture, lateral tarsal strip, and tarsorrhaphy, as shown on the photos on your right. We also gave the following medications and advice for daily wound care. We also monitored the graft in the harvest site. We referred the patient to general pediatrics for congenital workup and to plastics and reconstructive surgery service for graft evaluation. Shown on the right are photos taken from 3 days and 10 days post-operatively, as well as 6 weeks post-operatively, with note of good healing of the graft. Patient was seen by the pediatric service wherein imaging was requested. They also requested for genetic workup. Plastics and reconstructive surgery also saw the patient with note of 70% of graft take and advised graft cleaning. Cases like this are rare. It is usually commonly found in males than in females and usually associated with Down syndrome, ichthyosis, newborns in the Black population. It still has a known pathophysiology. However, multiple factors have been implicated, such as absence of an effective lateral canthal ligaments, lateral elongation of the eyelids, hypotonia of the orbicularis, vertical shortening of the anterior lamella, or failure of the orbital septum to fuse with the levator upon neurosis. So for this case, our final diagnosis is bilateral congenital ectropion, corneal scar on the left. To consider Down syndrome. Shown on the right is a picture of the patient after 1 year. That ends my presentation. Thank you and good day.
Good afternoon, everyone. I'm Dr. Wenwen He from Eye and ENT Hospital of Fudan University. I'm glad to share the case with all of you, meeting the challenge of post-double RK patients, how to make an accurate IOL power calculation. There is no conflict of interest. This is a 57-year-old male case. He complained blurred vision in both eyes about over 6 months. He had low vision with both eyes, especially for the left eye. When we look at the anterior segmental photograph, we can see that there were over 30 radial scars in both eyes, and at the same place, we can see 2 scars. He also had moderate nuclear cataract in both eyes. In 1980, he received myopic arch surgery to correct the myopia. However, 1 year later, he received the second arch surgery for both eyes for refractive regression. Here are the biometry examinations for the patients. In the IOL master reports, the IQ length for both eyes were over 27 millimeters, shows that he had high myopia, and the corneal curvatures were lower than the normal patients, about 41.86 diopters in the right eye and 41.40 diopters in the left eye. He also had a little bit higher PCA for the left eye, about 0.52 diopters. And when we look at the PanCam examination reports, we can find that he had against the rule corneal astigmatism in the right eye and with the rule corneal astigmatism in the left eye. OCT and the wide field fundus photo shows that there was no obvious abnormality in both eyes for the patient. Research reference for the post-RK IOL calculations, and according to the review from Professor Wang Li and Professor Kwok, lower accuracy in eyes that have undergone RK generally has been reported compared with eyes that have undergone myopic or hyperopic LASIK or PRK. The percentage of eyes within 0.5 diopter of target ranged from 29 to 62, and the RMEDAEs ranged from 0.38 to 0.8. Professor Barrett reported in 52 eyes that the Barrett True K history, True K partial history, and True K no history formulas produced 76.6%, 75%, and 69.2% of eyes within 0.5 diopters of refractive prediction error, respectively. And the Higis, Double K Holiday formula, and Hill methods produced 40.4% to 69.2% of eyes within 0.5 diopter of error. And patients with multiple cuts are more unpredictable, and results tend to be more hyperopic than expected. In this case, the patient had more severe cataract in his left eye, and we read his reports carefully. Looking at the PanCam topography and IOL master values, the key values were quite consistent, which means that the results were correctable. However, he couldn't tell the details of his archy surgeries, and we used several formulas with no history, including the Bagautdinov formula with no history, ASCRS online formulas, and EVO formula. The target was minus 1.5 diopters. With the measured PK values, both Bagautdinov and EVO predicts 13.5 diopter for the target. However, this patient received multiple cuts on his cornea, and the results tend to be more hyperopic than expected. So we finally choose the 14 diopters IOL to be safer. The patient was followed up for 1 month. Here are the results. He had better BCVA in his left eye, and he was satisfied with the results. However, we confirmed that he tended to have hyperopic shifts during the 1 month follow-up, but the result is still accurate compared with the target. So the Bagautdinov formula and EVO formula may be suitable for the post-RK patients with multiple cuts. That's all for my presentation. Thank you.
Good day, everyone. This is a case entitled Life in Plastic, Is It Fantastic? I am Janine Lucy Biliano from Southern Philippines Medical Center, Davao City, Philippines. I have no financial conflicts to disclose. Hyaluronic acid filler injection is a minimally invasive cosmetic procedure that has been growing popular for facial rejuvenation. Hyaluronic acid, or HA, is a biocompatible dermal filler which is a widely used substance for modern facial cosmetic enhancement. Although this procedure is relatively easy to do, devastating complications can occur, including irreversible vision loss. The Barbie doll forehead is a commonly performed procedure. This aims to achieve facial feminization and forehead contouring. This is done by injection of fillers to the forehead and glabellar area to produce a fuller and more feminine look, much like a Barbie. This is a case of CT, a 20-year-old male Filipino with vision loss on the right eye. 8 hours prior, hyaluronic acid filler was injected on the right forehead. Immediately upon injection, the patient had blurring of vision on the right, associated with sharp retroorbital pain radiating to the right side of the head. 1,500 units of hyaluronidase was allegedly injected subcutaneously thereafter. The medical, family, and personal history were unremarkable. On presentation, visual acuity of the right eye was hand movement with fair light projection and 20/20 on the left eye. On the right eye, pupil was sluggish and had a positive RAPD. There was exotropia and ptosis as well. The left eye was unremarkable. There was note of limited extraocular movements on the right eye in all gaze directions. First question. Blood supply to the optic nerve head comes from the letter A, central retinal artery, letter B, short posterior ciliary arteries, letter C, lacrimal artery, or letter D, optic nerve artery. The correct answer is letter B. Fundus examination of the right eye revealed grade 4 disc edema and peripapillary flame-shaped hemorrhages with relative whitening of the retinal nerve fiber layer. The foveal reflex was dull. No note of whitening of the retina, obvious emboli, or a cherry red spot. The left fundus was unremarkable. On neurologic exam, there was decreased sensation on the nasociliary nerve distribution. Fundus fluorescein angiography of the right eye revealed hyperfluorescence of the disc corresponding to the edema. However, the vessels follow the normal course and there are no obvious vascular dropouts. Optic nerve OCT revealed thickening of the RNFL and obliteration of the CDR on the right eye. Cranial MRA did not detect any embolus in the ophthalmic artery, but the smaller branches cannot be totally assessed. We did hyperbaric oxygen therapy for this patient and was co-managed with internal medicine for any embolic, infectious, or inflammatory problems. On hospital day 2, the patient had a sharp stinging pain on the right periorbital and forehead area. There was note of pustular lesions with erythema on the cranial nerve 5A dermatomal pattern with a Hutchinson sign and areas of subconjunctival hemorrhage. Question number 2. This is an inexpensive diagnostic test to detect lesions containing herpes virus. Letter A, serology. Letter B, viral culture. C, Jiang test. Or letter D, calcofluor white stain. The correct answer is letter C. To this patient, Jiang smear revealed multinucleated cells on Gibbs stain. We started this patient on acyclovir 500 mg intravenously for 7 days, and the rest of the medications as well. These photos show the early and late external findings following filler injection to the right forehead. Painful skin rash, as you can see, erupted on day 3 post-injection, and 1 month after, there was resolution of the lesions, ptosis, and ophthalmoplegia. However, the vision remained at hand movement with pair-like projection. In recent years, the injectable soft tissue fillers have become an increasingly popular option for cosmetic facial augmentation because of its versatility and promising results. HA is one of the most common dermal filler in aesthetic medicine due to their ease of administration, quick onset of action, and minimal recovery time for patients. When these are injected to the tissues, they can provide structure and elasticity by binding collagen and elastin. It is also much less immunogenic than its predecessors. The etiology of vision loss and other ophthalmologic complications after filler injection is usually due to retrograde arterial embolism into the branches of the ophthalmic artery, including the retinal branches. This is a representative figure of the arteries of the face, ocular, and nasal area. The anatomy of the face is complex and has a considerable amount of variation. During a glabellar injection, the supratrochlear and supraorbital arteries are at the highest risk. Injected filler material is presumed to access the ophthalmic artery retrogradedly via the supratrochlear, supraorbital, or dorsal nasal artery. The small particles can also migrate back to the central retinal artery and posterior ciliary artery origins, and this may result in particle dispersion into each arterial branch, causing a multifocal obstruction. There was a similar case by Lucashu last 2022 who reported a patient who had HA filler injected to the glabellar and nasal areas. There was also immediate vision loss, ophthalmoplegia, ptosis, and cutaneous changes. Same with our patient. So there was noted CRAO, ischemic optic neuropathy, and ophthalmic artery occlusion on MRA. Hyaluronidase was also given, and there was resolution of ophthalmoplegia and ptosis. However, there was also persistent loss of vision. Additionally, there are only 4 cases published in PubMed regarding herpes reactivation after HA filler. Possible mechanisms include local trauma, such as the direct damage to the axon by needle and tissue manipulation after filler injection, inflammatory reaction after filler injection, and systemic stress or immunosuppression. The approach to management is mostly clinical, and there are several ancillary laboratory examinations such as CTA, MRA, macular and optic nerve OCT, fundus fluorescein angiogram, perimetry, and Jiang smear. Ischemia-associated complications carry a grave prognosis and should be dealt within less than 90 minutes. In some cases, even early and aggressive treatments do not ensure complete recovery. Strabismus, ptosis, and ophthalmoplegia almost always resolve spontaneously after a few months, but visual prognosis remains very poor. The final diagnosis is anterior ischemic optic neuropathy, herpes zoster ophthalmicus, secondary to dermal filler injection on the right eye. This ends my presentation. Thank you very much.
Okay, thank you very much for excellent lectures. Now I open the discussion. Let me start from the first speaker from Philippines, Dr. Hana Vienne Gekosala. Sorry for pronunciation. I have a question. Could you explain me when was the operation performed? At what age of the child? How old was the child when the operation was performed?
At the time that the child was 1 year old.
Okay. And what about this scar, the cornea scar? Was it secondary scar? How do you think? Or was it the primary defect?
Yes, I think it was a secondary to the exposure keratopathy.
Okay, thank you very much. Do you have any more questions to this first speaker?
I have one if we still have time. How many reconstructive surgeries these children may need in the future? Because it's he or she is 1 year old, and probably it might be some other things in the future. So how many surgeries from your experience? Because I have none, so it's just my curiosity.
So actually, this is our first congenital ectropion, and we're still in communication with the reconstructive surgery, since we are also planning to repair the lower lid. However, we are still waiting for the patient, since the patient is from outside of this city.
Okay, thank you.
Okay, thank you very much. Are there any more questions? If not, let me comment the second presentation, which was very interesting. I agree that Barrett formula is very useful in those cases. In my experience, we do a lot of cataract surgeries on cornea patients, and we found Barrett formula really very useful in those cases, and I really recommend it. It gives very good results. What is your experience? Could you comment or ask questions? Any more comments to this lecture, to this presentation?
I have one comment, because we also do a lot, especially those with RK patients that are not easy cases. We still have problems even with this best formulas. So I just would like to ask, what is your experience if you don't have a pre-RK data? So what the formula Barrett, or maybe some more, or maybe just online if we don't have any data from the past?
Thank you very much for your question. Yes, it's a difficult case for all of the cataract surgeons, and in our experience, the Barrett's TrueK formula is the most accurate, and also ASCIS online formulas and Hedges formulas may be also recommended. And we usually use use all the formulas we can get to choose the mean value of all the formulas. Maybe it's more accurate. Thank you.
Thank you.
Okay, thank you very much. And let's move into the last presentation from Philippines. It is really very interesting, and we should always remember that there are side effects from ocular system from the eye in these procedures, dermatologic procedures, and I found very interesting this conclusion that dermatology, plastic procedures may lead to herpes virus reactivation, because we found a lot of people nowadays, I don't know why, maybe due to COVID or COVID vaccines, that we found a lot of cases with herpes reactivations after cataract surgery or after cornea surgery. So we always give those patients, when we have the history of herpetic problems in past, we give those patients a cyclovir 2 times 400 milligrams per day as a prophylactic. What is your experience? Do you have any questions?
Yes, thank you. For this case, this is actually our first case regarding the patient we had with herpes zoster reactivation. So, however, I've read in the literature that in patients who are at high risk of recurrence, we actually discourage this dermatologic treatments because they are at very high risk of reactivation. However, in other people who are somewhat has a lesser risk, so yes, we can give prophylaxis for these patients, antiviral prophylaxis.
And what about this particular patient? That was a man. Did he has any herpetic problems in past, or
None.
any history of
no, the patient had no history of any herpetic problems or disease before.
Okay, thank you. Any more questions?
I have one more, because we had this discussion some time ago in Poland. Is the hyaluronidase really effective in these devastating complications? Because in the literature there are controversial opinions, and if it is effective, what the timeline it's worth to be given to such a patient with going blind due to the filler in the forehead, for example?
So with regards to hyaluronidase, it can be given either subcutaneously or via retrobulbar injections. So actually, because of the rarity of these complications, there are no actual rate of success in these treatments. However, there are other case reports who claim to have good response with hyaluronidase, which actually, if not improved, it actually prevented worsening of blurring of vision or vision loss. However, of course, these cases are anecdotal, or there have been no really controlled trials for these treatments. However, if we decide to do this, we have to decide as soon as possible. So usually within the window of 24 hours for these patients.
Thank you very much.
Okay, thank you very much.
Thank you.
So we can move to the second part of our session. So let's start the second part of our cases, the next pre-cases.
Ladies and gentlemen, I would like to present the case of herpetic keratitis, which was diagnosed, monitored, and treated using corneal confocal microscopy in our clinic. My name is Agnieszka Kuligowska, and I want to declare that there are no financial conflicts of interest to disclose. Our patient was a 66-year-old female referred to the clinic due to redness, photophobia, and foreign body sensation in her left eye for about 5 to 7 days. She had no past history of such symptoms. Her best corrected visual acuity in the affected eye was 0.5 decimal, and intraocular pressure was 13 mm of mercury. Slit lamp examination revealed the epithelial dendritic ulcer in the upper corneal quadrants, which stained positively with fluorescein. We have also evaluated the corneal sensation with Cohen-Bonnet aesthesiometer, which was 2 in 6 in the upper quadrants and 6 in 6 in the other parts of the cornea. Central corneal thickness was 560 micrometers, and based on the physical examination, we diagnosed epithelial herpes simplex keratitis. As you can see here, there is a fluorescein staining, typical dendritic ulcer. As part of the diagnostic process, we also performed the corneal confocal microscopy using HRT-free RCM from Heidelberg to evaluate the dendritic defect area. The corneal confocal microscopy revealed the extensive area of the dendritic ulcer in the epithelial layer. As you can see here, this is the first picture. Here we have some healthy cells, and this is the ulceration area with some inflammatory cells. And the scan depth is here around 13, so between the superficial and wing epithelial cell layer. In the subbasal plexus, there are only few nerves visible, so only 1, 2, and 3 nerves, and they are surrounded by single dendritic cells. And there are also few pseudoguttae located on the endothelial area in the place corresponding to the epithelial dendritic defect. According to the diagnosis, the topical targeted treatment consisted of topical ganciclovir 5 times a day was implemented, and the first follow-up visit was scheduled 7 days after. And my question for you is here: is it really the epithelial form of hepatic keratitis? At the first follow-up visit, a significant improvement of the eye condition was observed. There were no signs of redness, photophobia, or misty vision. Patient's best corrected visual acuity in the affected eye was 0.5 decimal, and intraocular pressure was 12 mm of mercury. Slit lamp examination revealed only the dendritic corneal haze in the upper corneal quadrants, which stained negatively with fluorescein. The corneal sensation with Cohen-Bonnet aesthesiometer was 2 in 6 in upper quadrants and 6 in 6 in other parts of the cornea. Central corneal thickness was 558. Corneal confocal microscopy did not show any significant changes compared to the initial examination, so I've decided not to show it here, with the exception of the healed epithelial defect surrounded with some hyperreflective cells. Due to the corneal haze and we started the treatment with topical dexamethasone twice a day. And during the second and third follow-up visit, after 1 and 2 months, the slit lamp image of the cornea did not show any differences compared to the first follow-up visit. And still, there were no signs of redness or photophobia or misty vision. However, the patient's best corrected visual acuity improved, and corneal sensation decreased. In the center of the cornea, as you can see, it's 1 in 6, and in the lower quadrants, after 1 month, it was 5 in 6, and after 2 months, at the third visit, it was 4 in 6. CCT was almost the same, so 554. It's not a big difference here. Unlike the macroscopic image, the microscopic image showed significant changes in the structure of the cornea. After 1 month of treatment, there were no signs of dendritic ulcer in the epithelial layer, but a huge amount of dendritic cells in the basal epithelial layer and subbasal layer was observed. There were no corneal nerves visible in subbasal plexus layer. Maybe there was one nerve, but it's almost invisible. We've also observed the slight stromal involvement, as you can see here, which is in this third picture. These corneal sites are activated, they are hyperreflective and more dense as usual. And the endothelial layer is still involved. There are quite many pseudoguttae located on the endothelium in a place corresponding to the past epithelial defect. Due to the significant inflammatory response combined with the persistent haze, we decided to increase the dose of topical dexamethasone to 4 times a day. During the third follow-up visit, the slit lamp examination showed no differences, but there was a significant improvement of the corneal in the corneal confocal microscopy. There were visible nerves in the subbasal plexus in all corneal quadrants with slightly reduced reflectivity and number, and there were only few dendritic cells between the nerves in basal epithelial cell layer. The stromal and endothelial involvement were constant. We have decided to taper the steroid dose to 2 times a day and for 2 weeks, and then to 1 time a day for 1 week till the next follow-up visit. After 3 months of observation, there were no signs of HSV keratitis. Previous corneal haze was almost invisible. Best corrected visual acuity improved to 0.8 and remained at this level for the next 6 months. And there was a significant decrease of corneal sensation in all corneal quadrants. As you can see, 2 in 6, 1 in 6, and 3 in 6. And back to the corneal confocal microscopy. After 3 months, almost everything was perfect. Best corrected visual acuity improved, haze disappeared. In CCM, there were no signs of dendritic ulcer. All nerves were visible, and there were no deviations regarding their number or morphology. There were no dendritic cells in the basal epithelial layer, and there were no signs of stromal involvement, and there were only few pseudoguttae left on the endothelium. So we have decided to gradually discontinue the steroid. We have changed the active substance from dexamethasone to loteprednol 1 time a day and scheduled the next farewell visit in 3 months. Nevertheless, after next 3 months, the patient reported only slight irritation with no pain, no redness, no misty vision. Corneal confocal microscopy revealed a huge amount of dendritic cells in the basal epithelial cell layer and the subbasal plexus. The subbasal nerves were invisible again. There was neither the stromal involvement nor dendritic ulcer in the epithelial layer, and the endothelial involvement remained constant. According to the clinical picture, we decided to take a step back and return to the treatment with topical dexamethasone 2 times a day for 1 month and then 1 times a day for another 2 months. Next follow-up visit was scheduled in 3 months. After changing the treatment, the clinical picture stabilized. The last effective dose was retained due to the good response. As you can see, the morphology and the number of subbasal nerves is normal. There is no stromal involvement, and there are only few almost invisible pseudoguttae here at the endothelial level. Due to the persistent decrease in corneal sensation, the treatment with on-serum eye drops 6 times a day was initiated. So, was it really the epithelial form? Despite the fact that in the epithelial form of HSV keratitis, macroscopic changes are observed only at the level of corneal epithelium, microscopic changes occur in every corneal layer. And our conclusions are here. The development of modern imaging techniques, such as CCM, sets a new direction when it comes to the diagnosis and therapy of HSV keratitis. Confocal microscopy is a very valuable tool for monitoring the course of herpetic keratitis. It allows to evaluate the symptoms in the preclinical stage and modify and fully individualize the treatment to prevent the exacerbation of the disease. The fact that post-HSV microscopic changes are present at every layer of the cornea should be taken into account, especially while planning ophthalmological procedures that violate the integrity of the corneal tissues. Antiviral prophylaxis should be considered. These new diagnostic possibilities offered by confocal microscopy call into question the current classification of herpetic keratitis based on the disease location. Thank you for your attention.
Dear colleagues, greeting to you from Ukraine. Thank you, Polish friends, European friends, for helping in the victory of our country. Let me introduce myself. I am Katerina Hryzhemalska. I am head of Ophthalmology Department of National Pirogov Memorial Medical University, Vinnytsia City, Ukraine. And today I want to say to you my topic about changes of cornea as a complication of tomotherapy clinical cases. So, introduction. Tomotherapy is one of the treatment methods of oncopathology patients. However, because low-dose radiation is predominantly the treatment of first complication, such as cataract, retinitis, and optic neuropathy, are rarely encountered. Above all, one of the most common adverse effects after radiation therapy, changes of cornea. The purpose: to describe of severe manifestation of cornea changes as a complications of tomotherapy in patients with salivary gland adenocarcinoma. Materials and methods. Male patients 34 years old presented with complications, decrease of visual acuity of both eye, redness, discomfort, and light sensitivity. Patients had salivary gland adenocarcinoma in anamnesis and received radiation therapy. Ophthalmological examinations include general and special indicator of tears production, tear film breakup time, total tear production Schirmer test, slit lamp examination of the corneal staining by Oxford grading scheme, impressional conjunctiva cytology. What we have the results? As a result of examination was found that visual acuity ocular dextra 0.7, visual acuity oculus sinistra 1, intraocular pressure in normal by oculus dextra and oculus sinistra. Schirmer test ocular dextra 3 mm na minutes, oculus sinistra 6 mm na minutes. NITAP test ocular dextra 6 seconds, ocular sinistra 8 seconds. Corneal fluorescein staining examination by Oxford gradient scheme showed 4 in ocular dextra and 3 in ocular sinistra, and corneal abrasion in lower part of the cornea of the right eye. Impression cytology of conjunctiva showed squamous metaplasia by Nelson 3 in ocular dextra and squamous metaplasia by Nelson 2 in oculus sinistra. Patient received treatment during 6 months, tregalose-based drops, corneal reparants, anti-inflammatory therapy. So, riddle, are you agree with me that our patients have the next diagnosis? Dry eye disease, severe stage ocular dextra, dry eye disease, moderate stage oculus sinistra after radiation therapy. Conclusion. In individuals with ocular surface changes, the clinical symptoms of which developed against the background of radiation therapy, the long-term use of tregalose-based eye drops improved the functional indicators of the front part of the eye. This makes it possible to recommend the uses of eye drops based on tregalose in the complex treatment of ocular surface changes in cancer patients on the background of radiation therapy to improve the quality of life of these patients. Thank you for attention. Thank you support for Ukraine. Bardzo dziękuję.
Good afternoon. I want to start this presentation by thanking the organizing committee for inviting me to this talk yet again, like the other year. And I would like to name this presentation What a Downer, a Patient with Previous Eye Trauma. And my name is Alistair Gibbons. I work at the Bascom Palmer Eye Institute in Florida. So this is a 21-year-old male that presents for follow-up after a ruptured globe repair about 7 months prior. Vision was actually very good in the unaffected eye, but the left eye had 20/80 vision, and as you can see in the picture, there's definitely something wrong with it. Pressures were normal, 13 and 11. The prior history was as described, prior trauma in the left eye, and no relevant past medical history. Just to make things a little clearer, we've devised a timeline here that shows what happened from day one. So the original accident was blunt trauma in the left eye with a rock, which turned into a ruptured globe. Now, he presented to us 3 days after the trauma, as he was transferred here, and he had a 5.5 millimeter corneoscleral wound with iris plugging the peak pupil. Fortunately, we were able to repair this on the same day. And as you can see, about 4.5 months after the trauma, after the sutures were removed, his best corrected visual acuity in the left eye was 20/25, which is an excellent result. However, there was a lot of astigmatism, mostly irregular, that actually made us refer the patient for contact lens fitting. So something interesting we did in this case early on to try to diagnose this was use what we call argon laser mapping, and we asked one of our star residents, this is Dr. Ben Lin, with the help of Dr. Lily Zhang, that to shoot some laser spots into the eye. And basically the results are magnified on this slide, and as you can see inferiorly, when we use the argon laser to stain this area of concern, we can see that it blanches. However, when we use the laser argon to burn what we presume to be normal iris, it becomes dark, which is very consistent with iris. So at this point, we should ask ourselves, what could this be? Of course, the differential diagnosis includes a series of things: fibrous downgrowth, ICE syndrome, epithelial downgrowth, herpes simplex virus or varicella zoster virus causing uveitis with the pupillary membrane, or any other uveitis causing intense inflammation can course with this. Trauma with, of course, a lot of inflammation and scarring causing a pupillary membrane. Also, we can see this in chronic retinal detachments on occasion. And if the patient were younger, we would like to include persistent primary vitreous on the differential. Just to help us out a little bit, getting closer to the moment where we will reveal the diagnoses, this is a high-power hematoxylin and eosin staining demonstrating stratified mucosal epithelium that displays no definitive cytologic atypia. That means that it's normal, we're not concerned for tumor. And this is adjacent to heavily pigmented, morphologically benign pigment containing cells consistent with iris epithelium. So basically, this is the area that had the ectropin UV, and we were able to sample this part. Also, we have a cytokeratin staining that confirms that the stratified cells are in fact mucosal epithelial cells. You can see this in the asterisks, located adjacent morphologically benign iris pigment that you can see marked with the arrows. So at this point, of course, we must ask ourselves, what is this? And I think a lot of you know, and if you don't know, this is a case of epithelial downgrowth. So heading back to our case a little bit, just following up on what happened after the 6-month presentation, we basically have that the patient had a relatively good visual acuity, and he didn't have much progression of this membrane, so the decision was done to observe, but we had considered injecting him with intracameral 5FU. In July, the pressure did increase to between 20 and 30, and he was started on medical therapy, and now his gonioscopy did show significant anterior synechia and angle closure. As we can see, there's a severely constricted Humphrey visual field on the 24/2 analysis, likely would benefit from a 10-2 testing in the future, and his pressure was elevated all the way up to 38. So in spite of medical therapy, we definitely had something going on here. So the decision to implant an Ahmed clear path tube was made, and a little later, 2 months later, the pressure had improved to 21 millimeters of mercury. The vision was not great, but it did pinhole to 20/40, and we know he had some limited visual fields. So let's just talk a little bit about epithelial downgrowth in the last remaining 2 minutes of this presentation. This is when stratified squamous epithelial cells from the conjunctiva or cornea migrate through a wound and proliferate, causing intraocular inflammation and tissue damage. It's a very rare complication of ocular surgery or trauma, and it used to account back in the day for about 27% of all enucleations. And now, of course, we make smaller incisions, we do better wounds, and we also have more ability and knowledge on how and when to repair corneal lacerations and other perforating ocular traumas. The incidence is very rare, even considering a late series from like 1950s. The incidence is quite rare, and after PK, even that incidence is quite rare, but it's something that we do see even nowadays. The timing in general, this will appear about 5 months after the event, but it can be as early as 2 weeks and as late as decades after, most often within a year. And of course, the risk factors, as we said, surgeries, trauma, etc. But look for, we should really be suspicious in patients with multiple surgeries in the eye. The diagnosis, there's many ways to make this diagnosis. Of course, we have specular microscopy, confocal, anterior segment OCT, but I really like the argon laser photocoagulation trick. That works every time. Aqueous DAP, of course, we can use that to identify epithelial cells, and histopathology, of course, is still the gold standard. Complications are usually due to the fact of this aggressive and recurrent membrane. Glaucoma is number one, as we saw with our patient, but we can see other things happening in the eye. Within management option, we opted mostly for observation due to the fact that the membrane was stable, and we did have to manage this glaucoma aggressively. You can excise it surgically, but it can grow back again. Cryotherapy has been tried and described. Laser photocoagulation as treatment is an option, but it's rare. Antimetabolites are useful, but also can cause damage to other structures in the anterior segment of the eye. And of course, for these, we have the choice of methotrexate, 5-FU, or mitomycin. I want to thank everybody for their attention, and I hope you have a wonderful rest of your meeting. Bye.
Okay, thank you very much. I would like to thank all the speakers for very interesting presentations, and I open the discussion. As to the first presentation, I would like to conclude that confocal microscopy is not widely used in diagnosing and monitoring the herpetic keratitis. My question is, do you think that confocal microscope will affect currently used treatment regimens in treating herpetic keratitis?
According to the current standards in the epithelial form of keratitis, we most often use only antiviral agents, and after obtaining corneal epithelialization, the patient doesn't continue the topical treatment. The use of confocal microscopy shows us that the inflammation continues for many weeks in every corneal layer. So I think we should definitely reconsider the treatment regimens. I hope we will appreciate the role of the steroid also in the epithelial form as an inflammation quenching agent. And I think it can be assumed that complete reduction of inflammatory process will reduce the number and the severity of the recurrences in the next months of the treatment. So yeah.
Okay, thank you. I agree with you that we should taper the steroids very slowly, and the confocal microscope is a really very useful device to decide when to stop steroids, and how to taper them down. Okay, thank you. And are there any more questions?
May I?
Yes, please.
Because you have a great experience with confocal microscopy, and based on your presentation, it means that we should have any prophylaxis. So what to give the patient to prevent recurrences, and for how long? I mean, antiviral agents, steroids, and for steroids also, how long we should keep the steroids, based on their also cataractogenous and glaucomatogenous effects. What do you think?
I think that this is the role of the confocal microscope. So we should monitor the patient, because we really don't know. One patient will have the inflammatory process for 3 months, another for 6 months. So we need to monitor the patient, and then we need to taper the steroids slowly. As Professor Ulińska said, you cannot give the patient the steroid for example, 6 times daily for 3 months. Yeah, you need to taper it, and for example, change dexamethasone for to loteprednol. Sometimes it's only the very small dose every 2 days, but we need to think about it. And about the antiviral agents, if the cornea is epithelialized, so we have the epithelium on it, then we shouldn't give patients antiviral topical agent, because it doesn't work. So,
but general, oral, yeah. But
oral. If it's the stromal form or the endothelial form, then if it's the next recurrence, so the 5th time, 6th time of then it's there are some recommendations that we can keep the antiviral agent, oral antiviral agent, for 1 year, even 1 year, 2 times daily. First 3 weeks is 5 times a day, 400 milligrams, and then we can taper it to 2 times a day for 400. And you can keep it for 1 year in such cases. And in case of cataract surgery or corneal transplant, then the dose should be bigger for this 1 month, and then tapered to 2 times.
Okay, thank you.
Okay, thank you. Everything depends on immunological status of the patients and the particular patients, and the confocal microscope give us another tool to monitor this treatment.
Mm-hmm.
Okay, thank you very much. So let's move to.
Sorry, may I have one question?
Yes, please, of course.
Thank you for case. Very interesting. I have only one question. How long time your patient using antiviral general therapy, and what general therapy viral he using? Thank you.
So in this particular case, it was only topical therapy, antiviral topical, because of the it was epithelial form. But in other cases, in stromal cases, for example, we in the first time we use for 3 weeks up to 1 month, and then we stop it. But if it's the recurrence, that's, as I said, for even 1 year.
Thank you.
Thank you.
Okay. Thank you very much. If there are no more questions, we can move to the next speaker, from Dr. Katerina from Ukraine. Do you have any questions to this interesting presentation?
It was very interesting presentation. I have one. Actually, what was the eyelids appearance in these patients after radiation therapy? Did you check meibomian glands? Because sometimes this evaporative component may be due to the obstruction of the meibomian glands. And if so, what treatment do you recommend?
Thank you for your question. Yes, we have changes of meibomial glands. We have dysfunction of meibomial glands. We do meibomiography of these patients. And of course, we give the treatment of hygiene of eyelids. We're using Teagel. We're using Blefaclin for more like 1 month. For this patient.
Okay. Did you use any masking probing
No.
for the obstruction? No. Mm-hmm. Thank you.
Okay, this is a very good presentation because shed a light on this problem that oncologists should always refer those patients with to ophthalmologists due to those dry eye problems.
And I think it's not only one of type of these cases, because I think that if we are think about some other localization of tumor, it's maybe brain, it's maybe some lower organs. I think these patients the same have dry eye syndromes, and maybe in future we think about these patients and do some case report.
Okay, thank you very much.
Thank you.
Any more questions?
No.
If not, so thank you again, and let's move to the last presentation from Bascom Palmer Eye Institute, Dr. Alistair Gibbons. I open the discussion. I have one question. What about removing this epithelial tissue from the corneal surface and doing, for example, lamellar transplantation, DSEC or DMEC? What is your experience?
I don't know if the doctor is with us.
Okay.
So pity, because I had the same curiosity. If they just remove this maybe with bevacizumab or any anti-VEGF before, just to prevent bleeding.
Okay.
Okay, pity.
Pity. Okay. So I think we can close our discussion. If there's no any more question, I'd like to thank all the speakers for excellent presentations, and thank you very much.
Thank you. Thank you.
Thank you.
Good afternoon. I don't know if we are all on, but I will start. My name is Agnieszka Kadaszewska. I am an ophthalmologist from Poland. Thank you, Professor Andrzej Grzybowski, to invite me to moderate with this Enigma session in Case Reports of Ophthalmology 2023. With me, I hope, Professor Ferenc Kuhn is with us.
Yes, I'm here.
Okay, thank you.
Hello,
Welcome.
everybody.
Hello. And Dr. Perfetto Tagampang. I don't know if I am good with pronunciation. Welcome. And I would like also to introduce our speakers. In the session 3, Enigma session, we will have 7 case reports. And they were Dr. Paul Villa-Castin, Dr. Riley Udasco, Dr. Lixia Lu, Dr. Chen, Dr. Yair Morat, Dr. Alejandra Santiago Diaz, and Professor Ferenc Kuhn. So let's start.
Good day, everyone. I am Dr. Villa-Castin, a second-year resident at the Philippine General Hospital, here to present our case report entitled Breaking the Ice, Unraveling a Rare Case in a Male Patient. So we are presented with a 37-year-old male with a 4-month history of foggy blurring of vision of the left eye with mild eye redness. He was initially seen by another ophthalmologist and assessed as a case of glaucoma and treated with pilocarpine, dorzolamide with timolol combination drops, and brimatopros drops. However, presence of symptoms led to consult at our institution. So, focusing our PE on the left eye, visual acuity was 20/58, improving to 20/46, with the equilibriously reactive to light pupils. However, we noted correctopic pupil for the left eye with grade 2 RAPD. IOP was initially 41 for the left eye and dropped to 30 after 1 drop of timolol with brimonidine combination drops and 1 tablet of acetazolamide. Showing slit lamp photos of the left eye. On the left photo, we note iris atrophy inferiorly and iris nodule superiorly on the right photo with ectropin UV under. Gonioscopy was done, showing closed angles with peripheral anterior synechiae on all quadrants for the left eye. Fundoscopy shows hazy media with an averagely sized, slightly pale disc with distinct disporters, coupled with this ratio of 0.9 with generalized rim thinning. OCT was done, showing generalized ganglion cell layer thinning of the left eye with superior and inferior RNFL thinning of the left eye. Perimetry shows severe generalized defects with clustered points of depression in all quadrants, sparing the central field, which was consistent with the advanced glaucoma. So the patient was referred to 2 subspecialties. The glaucoma service made the plan to do a glaucoma drainage device implantation with a preoperative ultrasound biomicroscopy and to medically manage the patient while awaiting the OR. Patient was also seen by the external diseases and cornea service, where they did a baseline specular microscopy, suggested to do also a preoperative ultrasound biomicroscopy or an OCT angiography. They also suggested to do a clear lens extraction and suggested to place the tube more posteriorly behind the iris or the pars plana. So here is the baseline specular microscopy done. The left photo shows normal cells in the right eye, and the right photo shows the left eye with abnormal cells, which are described as endothelial cells with well-identifiable nuclei resembling the confocal microscopic appearance of corneal epithelial cells. Here's the ultrasound biomicroscopy showing retrotrabecular contact due to the peripheral anterior synechiae. Operation was done for this patient as planned, showing here an intraoperative photo showing the tube in the sulcus with an intraocular lens implanted. Day 1 post-op showed a VA of hand movement good light projection with good corneal discrimination.
The tube was barely seen with blood clots surrounding it, hazy cornea with anterior chamber inflammation. IOP was brought down from 21 preoperatively to 7 and was sent home on the following medications. Day 6 post-op showed the same VA, however, IOP was now increased to 62, probably due to the blood clots around the tube. Patient was restarted on medical management and an surgical plan of an anterior chamber washout with tube repriming, grip cord adjustment, tube priming, repriming for the left eye. Here's a second operation showing intraoperative findings of a membrane connected to the iris covering the tube. An iridectomy was done over this area to prevent further bleeding and pain. After the reoperation, the initial VA was again hand movement with good leg projection. However, still with a hazy cornea and anterior chamber inflammation. However, we now see the tube more clearly without the blood clots. IOP was now 26 and the patient was maintained on thymodal drops while await for 1 week before discontinuation. On subsequent follow-ups, we now note that the patient's visual acuity improved, best corrected to 20/21 with an IOP of 10. Cornea was now clear with formed chambers. Tube was still seen as sulcus with no touch of the iris or the cornea, with no plate exposure. So what are the features of the disease presented? Is it A, collection of conditions characterized by the corneal adherent corneal endothelial cells that behave as epithelial cells, or B, an unilateral disease with high intraocular pressures from angle closure glaucoma, reduced vision from corneal edema, and unusual iris appearances? Or is it C, a disease that typically affects young females more than males, or D, all of the above? So the answer is D, all of the above. So for this discussion, we need to talk about the corneal endothelium. So this is a single layer lining the inner surface of the cornea, and it maintains corneal transparency. However, in this disease, we note that again, the endothelium is altered. So Campbell hypothesized through the membrane theory that this disease is caused by a proliferation of corneal endothelial cells that has the ability to migrate into surrounding tissues. This can be seen in specular microscopy, as seen earlier, histopathology showing epithelial-like phenotype in endothelial cells, and immunocytochemical evidence shows a broad-spectrum cytokeratin in these cells. So we can see on slit lamp battered bronze appearance of the corneal endothelium with high peripheral anterior sneaking on gonioscopy. There are 3 variants for this disease, and for our patient, it was consistent with a variant that has tan pedunculated nodules and diffuse pigmented lesions on the anterior iris surface. So what are the sequelae of this disease? Is it A, secondary angle closure glaucoma, B, corneal edema, C, iris atrophy and hole formation, or D, all of the above? So it's D, all of the above. Again, here are the sequelae of this disease. Secondary angle closure glaucoma is caused by the altered corneal endothelial cells that move posteriorly onto the trabecular meshwork. PAS is from the contraction of this tissue within the angle. Corneal edema is also a result of high IOP and the subnormal pump function of the altered endothelium. Iris atrophy and hole formation is due to the stretching of the iris in opposite direction of the correctopia. So besides glaucoma workup, we should also do specular microscopy to differentiate from other diseases and to show the abnormal cells that are characteristic. We should start with medical management, and to do eventual surgical management. Trabeculectomy has been shown that in 53.8% of patients that will require glaucoma drainage device implantation. GDDH has been shown to have a better survivability in the long term. However, it's important to place the tube properly. Lens extraction is also done to create more operating space and to make it easier for corneal transplant in the future if it will be needed for corneal decompensation. So in conclusion, this is a rare unilateral syndrome that affects females more and can cause corneal edema and glaucoma. Early diagnosis, timely management, and close follow-up are paramount in preventing complications. So what is this disease? It's none other than eye syndrome with secondary angle closure glaucoma with the Cogan-Reese syndrome variant. Here are my references, and thank you very much.
Good day. I am Riley Marcio Odasco from the Manila Doctors Hospital, Philippines, presenting the eyewitness. I have no financial disclosure. Patient RU, a 29-year-old male, Filipino, Catholic, known as asthmatic, with a chief complaint of masses on the face with facial deformity. 20 years prior to consult, the patient initially complained of persistent episodic nasal bleeding with nasal congestion. Consult with ENT specialist and underwent functional endoscopic sinus surgery in which pathological diagnosis was glial choristoma. 19 years prior, repeat surgery done due to recurrence of nasal mass. In the interim, patient was asymptomatic. 17 years prior, again recurrence of nasal mass, however on imaging revealed extension to inferior extraconal space of the right orbit. Repeat surgery done, histopathology revealed inflammatory pseudotumor. 15 years prior, patient now noted a palpable, hard, non-tender, non-movable mass on the right infraorbital region and zygoma. Imaging revealed an enhancing lobulated soft tissue mass in orbital, periorbital, and nasal region, then underwent a debulking procedure. Patient then underwent a 1-year trial of IV corticosteroid treatment. In the interim, annual report imaging of the orbits were done for monitoring. Stable findings were noted until 7 years prior. Recurrence of palpable masses on the orbital region, excision was done, which showed same histopathologic findings. Underwent resumption of adjuvant corticosteroid therapy. Again, patient remained asymptomatic until 3 years prior, recurrence of palpable masses in the zygomatic and lacrimal area. Excision was then done. Pathologic diagnosis revealed fibrocollagenous tissues with atypical lymphoid proliferation and benign polyclonal plasmacytosis, and an IHC stain showed CD20 positive in B lymphocytes and CD3 positive. 2 years prior, recurrence of palpable masses was noted. Consult with a different ophthalmologist was done. Repeat orbital scan showed multiple enhancing soft tissue lesions and was referred to a medical oncologist for trial of rituximab therapy. Repeat imaging post-rituximab therapy showed stable lesions. Attending physician then requested for repeat excision of the palpable masses. On IHC stains done and supports the same findings for CD3 positive, CD20 positive, CD68 positive, and S100 positive. Regarding the IHC stains as shown, what phenomenon can be seen in these macrophages stained with CD68? A. Phagocytosis, B. Satelitosis, C. Necrosis, D. Emperipolysis. Presently, patient is on active disease monitoring. Most recent scans done a month ago showed stable findings. Past medical history. Patient is asthmatic, multiple surgical history of functional endoscopic sinus surgery, and excision of orbital masses, and spectacle use of 10 years. For the physical exam, BCVA is 20/20 for both eyes. On external exam, on the right, a 2.3 linear scar. Below the medial canthus, a 2.8 cm curvilinear scar over the right zygoma, and on the left, a 2 cm linear scar below the medial canthus, and a palpable, non-movable, non-tender solid mass below the medial canthus. The rest of the physical exam findings are unremarkable. With the information presented, what is the likely diagnosis? A. Echinolder-Rossi-Dorfman disease, B. Non-Hodgkin lymphoma, C. Extrapulmonary tuberculosis, D. Langerhans cell histiocytosis. When thinking of causes of lymphadenopathy, we have the mnemonic Chicago: cancers, hypersensitive syndromes, infections, connective tissue diseases, atypical lymphoproliferative disorders, granulomatous disorders, and other unusual causes. Rossi-Dorfman disease is a rare benign tumor characterized by an abundance of histiocytes in the involved tissue. Typically presents with painless bilateral cervical lymphadenopathy, but may also present at extranodal sites, 11% of which involve the eye, orbit, or ocular adnexa. The incidence is 1 in 200,000, more common in young children to young adults, with no predilection to gender. Pathophysiology is generally unknown. However, according to a review by Kai in 2017, pathogenesis is theorized to be due to monocytes which are recruited to inflammatory lesions by disturbance of homeostasis due to chronic infection or exaggerated immune response, or even inherited genomic mutations that would lead to defects in maturity, differentiation, and antigen presentation of macrophages, which would lead to triggering histiocytosis. Clinical features would be enlarged lymph nodes, most commonly affecting a bilateral cervical lymph nodes. May have symptoms such as cough, nasal congestion, abdominal pain, bone pain. On diagnostic exam, patient may have anemia, leukocytosis with neutrophilia, elevated ESR, hypergammaglobulinemia. Pathologic features. A distinct feature would be histiocytosis with emperipolesis. Histiocytes are large and foamy cells referring to tissue-resident macrophages, where their role is in antigen presentation and in the phagocytosis and removal of cellular debris and pathogens. Emperipolesis, M inside, peri around, polesis attachment to another cell. Basically, it is the presence of an intact cell within the cytoplasm of another cell. Tissue biopsy would also show marked fibrosis of lymph node capsule with lymphocyte and plasma cell infiltration. On IHC stain, positive for S100, CD68 positive, and negative staining for CD1A. Regarding the IHC stain image I showed previously, is an example of emperipolesis. Radiologic features, nodal involvement on PET-CT. Extranodal involvement will show a soft tissue lesions enhancing on CT or MRI. Extranodal manifestation of Rossi-Dorfman disease, 43% of cases involved extranodal manifestations, 11 of which involve the eye, orbit, or adnexa. Several journals reported that Rossi-Dorfman may present as different ophthalmologic manifestations such as a nodule, conjunctival mass, pharyngeal nodule, eyelid swelling, orbital mass, salmon-colored epibulbar mass. Current treatment options. There are currently various treatment options based on expert opinions, some of which are observation without treatment due to spontaneous resolution, surgical debulking, medical therapy such as systemic steroids, chemotherapy, and biologic therapy. In summary, the demonstration of unique S100 positive CD1A negative histiocytes with emperipolesis would merit a diagnosis of RDD. However, the definitive diagnosis also requires correlation of appropriate clinical presentation with radiologic and laboratory data. So the patient presenting with multiple palpable masses on the face, presenting with multiple enhancing soft tissue lesions on scans, and on immunohistochemical staining, CD20 positive, CD68 positive, S100 positive, with emperipolesis, was given the pathological diagnosis of Rossi-Dorfman disease. Before I end my presentation, I would like to reveal that I am the eyewitness. Thank you.
Hello everyone, I'm Liu Lixia from the Second Affiliated Hospital of Zhejiang University, China. I'm so glad to be here to share with you a severe case with progressive restricted esotropia and hypertropia. This woman, 52 years old, came to my office. She complained of progressive deviation of the right eye for more than 40 years. There was no history of diabetes, hypertension, ocular or brain injury. The best corrected visual acuity of the right eye is counting figure. The right eye is highly myopic with long axial length of approximately 31 millimeters. Choroidal plaques was seen in the left fundus of the right eye, while the left eye was normal with axial length of approximately 24 millimeters. The CT images demonstrated that the temporal quadrant of the posterior portion of the right eye prolapsed out of the muscle cone, which displaced the lateral rectus inferiorly and the superior rectus medially. Binocular movement testing revealed that the right eye was restricted in superadduction and abduction. While this patient presented with progressive esotropia and hypertropia, restricted ocular movement, and high myopia, what is the diagnosis? Well, maybe you just had the right answer. It's heavy eye syndrome, which is also named as highly myopic strabismus. The leading theory explaining the cause of this disease is as follows. superior temporal quadrant of the posterior globe prolapses out of the muscle cone, secondary to myopic global elongation, causing global herniation between lateral rectus and the superior rectus muscles, thereby displacing lateral rectus inferiorly and the superior rectus medially. Inferior dislocation of the lateral rectus increases introduction, and medial dislocation of the superior rectus increases adduction, leading to limited superadduction and abduction respectively. The degree of the dislocation of the globe could be measured by the angle between the lateral rectus and the superior rectus facing the supratemporal quadrant of the orbit. The letter G noted in the MRI images. The angle in heavy eye is significantly higher than that in normal eye. There are several surgical techniques for the treatment of heavy eye syndrome. Given the dislocation of lateral rectus and superior rectus in patients with heavy eye syndrome, it is often necessary to correct the deviant muscle path. Yokoyama's technique is the most preferred technique for pushing the globe back into the muscle cone. There are other techniques such as Yamada procedure, silicone band loop myopexy, and the partial Jensen's technique. The surgical technique used is largely based on the surgeon's preference and proficiency in a certain technique. Well, which technique did I choose for this patient? I chose partial Jensen's technique. Firstly, the lateral rectus and the superior rectus were isolated and split. Secondly, the superior part of the lateral rectus and lateral part of the superior rectus were sutured together at approximately 15 mm posterior to the limbs by 5-0 double arm suture to help put the globe back into the muscle cone. Thirdly, intraoperative forced adduction testing revealed a tight medial rectus, and medial rectus recession was added to improve the movable range of the globe. At 1 week post-operation, binocular movement testing revealed that the right eye was improved in superadduction and abduction. Small residual esotropia and hypotropia of approximately 5 degrees was achieved. The patient has aesthetically acceptable deviation. She was satisfied with the surgical outcome. Now, it's come to the conclusion. Heavy eye syndrome typically presents with progressive esotropia and hypotropia, causing limited abduction and superadduction in a high mouth. Orbital imaging is very important and should be undertaken to demonstrate the anatomical abnormality and muscle path to confirm a definite diagnosis. Loop myopexy restores the normal anatomical relationship of lateral rectus and superior rectus. In addition, medial rectus recession reduces abduction restriction. So, loop myopexy together with medial rectus recession, which is also named as augmented loop myopexy, is often effective in correcting heavy eye syndrome. Well, that's all about this case. Thanks for your listening.
Hello, my name is Howie Chen from Zhejiang International Eye Center, China. Today, I would like to present a case with an iris tumor. This is a 25-year-old male. The complaint is burn in the right eye for 2 months. and there was also some eye redness but no eye pain or headache. The patient had a past history of fever, cold, and skin rash 6 months ago and was diagnosed as tuberculosis and get improvement after treatment at a local hospital. The visual acuity was 0.12 and the intraocular pressure was normal. So this anterior segment photo, so there's a vascularized tumor on the iris and there is also some anterior segment cells. And the anterior segment OCT, so this tumor is a solid tumor, and again the UVN, so it is a solid tumor and the tumor did not involve cerebral body. The V-scan and the slot, so the retina is normal. And what's the cause of iris tumor? And this is an article from Carol Seal that most of the iris tumor are melanocytic tumor, and some of them may be vascularized tumor or metastatic tumor or non-neoplastic stimulating lesion, and some of them are cystic tumor. And we found that this patient also have skin lesions throughout the body, and blood test so that the lymphocyte decrease and also the antibody for HIV is positive and the anti-syphilitic antibody is positive too. And we asked the history again. The patient was diagnosed as AIDS 6 months ago, but he discontinued the medicine by himself. So is this patient ocular syphilis? And we checked the literature and we found that there is a case report on New England Journal of Medicine about 30 years ago that there is patient also have this iris tumor and skin rash, and there's also some report of the iris tumor in ocular syphilis in his report on Lancet and Retina. And we compare our case to the case on New England Journal of Medicine. We found that these two cases look quite similar. And so we start anti-syphilis treatment. However, the lesion did not get improvement. So we can see that the lesion become worsened after the anti-syphilis treatment, and the iris tumor also become worsened after the treatment, and the visual acuity decreased to counting finger. So this is the anterior segment OCT also show the enlargement of the iris tumor. So we consider the diagnosis, and we check the syphilitic antibody on the aqueous tumor, and we found that the GW index is less than 2. And we also checked the interleukin-10 versus interleukin-6, and also it did not spot intraocular lymphoma, and it also do not look like the carposid sarcoma because there's no report of this sarcoma on iris. And so what is the cause of the iris tumor in this case? And we found that that the patient get worsened after the anti-syphilis treatment. So the patient, before he received the antibiotics, the patient also received prednisolone to prevent the JH reaction, and also the patient also received topical corticosteroid. So whether the corticosteroid wasn't the disease, and we've seen that this patient may be secondary to some kind of infection because the corticosteroid wasn't the condition. So we conducted this metagenomic next generation sequencing, and we found that in the skin and also aqueous tumor there is a fungus called Thalomyces magnifici. So it is a fungus in both skin and aqueous tumor. And what's this fungus? So it is opportunistic episode and seen usually in the patient with immunodeficiency, and it is endemic in Southeast Asia, South China, and North India. And the infection is usually by respiratory system, and the patient usually have the skin and lymph node and respiratory lesion and fever. So there are also some case report of this magnified ocular infection, but none of them reported a single iris tumor. And we treat this patient with oral antifungal agent. So we give him vericonnazole for the treatment, and also topical antifungal eye drop. And the patient get much improvement after the antifungal treatment. So you can see that this is the photo 8 weeks after the antifungal treatment. So you can see that the skin lesion get much improvement, and also the iris tumor almost completely regress after the treatment, and the visual acuity improved to 0.8 after the treatment. And this anterior segment OCT also showed the almost completely regression of the tumor. So to summarize, that this patient have iris tumor on 1/4 of the iris, and also have skin erosion, and the patient have HIV positive and syphilis antibody positive, and corticosteroid wasn't the disease. And the next generation sequencing identify a fungus called Tyrosmycin magnifique, and the oral and topical antifungal treatment can promote the completely regression of the iris tumor and the vision recovery. So this case report was published on the Ocular Immunology and Inflammation. Thank you very much for the listening.
Thank you, all the speakers. I am opening the discussion. Lecture number 1, Dr. Villa Castin was talking about Cogan Rees. Any questions from the co-moderators or?
I am just curious with Dr. Villa Castin's case report, is there a chance later on in life that the AMID valve or the aqueous drainage device will be changed, considering that this case is chronic?
I've seen some patients that already have a second sometimes a second tube, but it's more of trying to control the pressure, probably through medical management now.
Okay, thank you.
And I have also the question to this lecture. Did you try any other options in other drainage implants, like pressure flow from mixed procedures? Maybe it may be less invasive.
I haven't read studies yet about MIGS for this kind of case, so I'm not sure if, what the survivability of a MIGS in this case.
Okay, thank you. Any other questions? Okay, so let's move to the second paper, the second lecture, Dr. Udasco, Rosai-Dorfman disease, very rare. Any questions here? I have one. Can any of you consider that it might be metastasis from the cancer in the body, like colon cancer or any other cancers?
Well, actually, there's this test that my pathologist was, or my oncologist was suggesting for me to do, since I have one recurrence of a mass. They want me to do this test to check out for any cancer cells. It's still in pending, maybe in the coming year. But hopefully, if it's done, it'll be a negative result.
Okay. Any other questions to this case? If not, let's move to the third one. To the heavy eye syndrome. Any other questions?
I was just curious, because was there any treatment for the myopia also done after the operation? Glasses, contact lenses, or for this patient?
No, because the VA of the right eye is counting figure, and we don't have that. We had no surgery about the high myopia.
So this eye was amblyopic?
Yes.
So because what degree of amblyopia this eye had, the eye which turned, which made this squint?
The right eye is about 18
What was the vision? Maybe let's, because if the vision was poor, maybe that's why it ended up with such a big esotropia.
And the vision of the right eye is counting figure. And we just improved the facial appearance of the right eye. And nothing did for the visual acuity.
Okay. Anyway, and because there was a quite of extensive surgery done, do you consider the complications such as anterior segment ischemia in the future? And is there any method to prevent the anterior chamber ischemia? Because you did 3 or 4 muscles. It's kind of extensive strabismus surgery. I'm just curious.
Yes, the surgery is done on 3 muscles, but we just the superior part of the lateral rectus and the lateral part of the superior rectus was sutured together. We can see it's one muscle, and together with the median muscle, it's 2 muscles. So there's no complications on this patient.
Okay, thank you. Any other questions from the audience or from the co-moderators?
Was there any, for example, retinal exam? Were there any retinal examination or laboratory examinations done before the surgery was started?
But you mean the bilateral surgery?
No. Yes, before doing it, retina examinations done.
No retinal surgery was done before the strabismus surgery.
How about examinations?
Examinations of
laboratory.
the
Retina.
Yeah, it's just the fundus of which is often seen in high myopia eyes.
Just fundus. All right.
Yes.
Okay. Thank you. So we have also any other questions? Sorry. If not, let's move to the ocular inflammation. Lecture number 4. Any questions here? Comments?
Yes, I do have one.
Okay.
I think if a biopsy had been done at the beginning, it would have yielded a diagnosis much faster and a correct one at the first attempt.
So yeah, I think so.
Yeah. Thank you, Professor Kuhn, for this important comment. Yes, I agree that the biopsy, especially the sequencing, the next generation sequencing, will help us to identify the pathogen. But because the patient have syphilis, and also we found a similar case in literature, so we firstly diagnosed as syphilis. But you are right that if we conducted this sequencing firstly, we may make the correct diagnosis earlier.
Yeah, I understand that it's very easy to be clever after, so I'm not criticizing you. I'm just saying, in a case similar to this in the future, that would be a very quick and easy way to have a diagnosis.
Thank you.
But do you think that the biopsy should be done together with the vitrectomy, or rather just anterior segment sampling the lesion? I'm just asking you, Ferenc, what you mean biopsy.
I think in this case, a simple needle biopsy from the tumor itself would probably have helped without any further intervention.
Okay. Any other questions, comments? We still have time.
I was just thinking, for the case about this biopsy in the anterior chamber, because I think there are some needles which are gauge 31 or 32 that the dermatologist uses. It's short, it's not so long. The moment that you make it enter through the peripheral or limbal area, it's just the right touch that it touches the, what you call, the nodule or any mass, that you can aspirate some of it and even aspirate a little from the aqueous. And it is just my 2 cents of worth right now, because that is what I use, for example, if I do some anterior segment injections. And it's very, very small. And in fact, it doesn't even leak the moment you bring it out.
And do you think that, did you consult that case with dermatologists, because the patient you show had very prominent skin lesions? And what was the conclusion? Maybe here.
Yes, I did consult the dermatologist. So they also think that this case looked like a syphilis case. So they decide to treat use antibiotics to treat the case.
Okay. Thank you. So we can move to the next presentation, the 5th one, I think.
Hello, my name is Professor Yair Morad from the Tel Aviv University in Israel, and today I would like to talk about lateral rectus fixation to the orbital rim for complete third nerve palsy. Complete third nerve palsy is a very challenging surgical problem, mainly because the only active muscles are the lateral rectus and the superior oblique, and they have no antagonist to counterbalance their action, and therefore the eye drift to exotropia and hypotropia and cannot move anymore. Past surgical treatments that were suggested for this problem were maximal horizontal resection and resection of the medial, resection of the lateral, but this usually ended up in exotropia. Another surgeons proposed to use the active superior oblique tendon, which is still active, and transpose it medially to the medial rectus insertion, so it will counteract and balance the effect of the lateral rectus, but this procedure ended up with hypertropia and exotropia again. And even myectomy of the lateral rectus to completely eliminate its effect failed, and all the cases drifted back to exotropia. About 24 years ago, to be exact, we proposed another idea to take the lateral rectus and transpose it behind the globe to the medial rectus insertion, and in that way to convert the lateral rectus action from abductor to adductor, hopefully, and to achieve ortho alignment that way. And this is the baby that we operated on. You can see that he looks very happy and ortho to begin with, but by the age of 8, the eye started drifting to exotropia, and by the age of 16, the eye is in exotropia and hypertropia, and he's not satisfied and he needs another surgery. Another idea was to split the lateral rectus and transpose the upper half above the optic nerve to the upper part of the medial rectus insertion, and the lower half beneath the optic nerve to the lower part of the medial rectus insertion, and in that way to completely eliminate the abducting force of the lateral rectus. This surgery was very successful to begin with. The initial results, mainly Linda Daggy from Boston performed this surgery, but in a worldwide study that was done on 89 patients from around the world, only 70% were successful, 30% had technical challenges during the surgery, and 11% had sight-threatening complication, mainly because of serous choroidal effusion, because the lateral rectus, when it transposed behind the optic nerve, sometimes exerts pressure on the venous drainage from the eye and creates choroidal effusion. So what we thought was that if the lateral rectus always win, let's just take him out of the equation. And this is what we proposed. This is a paper that we published in 2005. Lateral rectus disinsertion and reattachment to the orbital rim, together with stenectomy of the superior oblique and resection of the medial rectus. And this is a sketch of the procedure. We completely eliminate the abducting force of the lateral rectus by connecting it to the orbital rim and preventing any contact between the lateral rectus and the globe. And I would like to show you a video of this procedure. This is a 16-year-old boy with congenital third nerve palsy and ptosis. He came for us from Ukraine. And the left eye is in exotropia and hypertropia, and this is the surgery that we performed. You can see that the eye is in exotropia and the lateral rectus is extremely tight. You cannot even pass the eye over the midline to adduction. And now we hook the lateral rectus and we free it from the attachments, and now we pass a needle of four vicarious sutures with a long needle that can go all the way to the periosteum. Now we feel for the periosteum and we bluntly expose the tissue above the periosteum in the orbital rim, and now we pass the needle through the periosteum, both needles, so the muscle is now attached to the periosteum and it's not attached to the globe in any way. Now it's very important, here we cut the suture, now it's very important to prevent any contact between the muscle and the globe, and for achieving that, we close the tenon capsule over the globe so it will separate between the globe and the lateral rectus. Hopefully that will prevent any adhesion of the lateral rectus to the globe and any abducting force that the lateral rectus can exert. And now we're closing the conjunctiva. And the next step is to expose the superior oblique tendon. This is the superior oblique, and we perform a tenectomy. We simply cut a chunk of the tendon, and now you can see that the eye is moving freely without any adhesion to the superior oblique. And now we expose the medial rectus. We are doing 8 millimeters resection of the medial rectus. You can see that here. And it's very important now that where the eye will be now will be it will stay there. So the eye should be dead in the center, or orthophoric completely. So we do that. We see that now the eye looks, it's not exactly in the center, so we add a small plication. And now the eye looks exactly in the center. We're satisfied, and we can close the conjunctiva. And it will stay that way forever, we hope. And this is the boy after surgery. You can see he still has ptosis, and he has some abduction movement, some adduction movement, because there is no counteraction to the medial rectus now, and hopefully he will stay like that in ortho. He's very satisfied. This is another patient. This is the first patient actually that we operated on with exotropia and hypotropia. This is how he looked before surgery, and this is how he looked immediately after surgery, and this is how he looks today. He is still ortho, and he still has some abduction and some adduction movement. This is another baby with complete third nerve palsy, and this is how he looked 12 years after surgery, just before his bar mitzvah, and he's very happy. The eye is in the center, although there's no movement to adduction or abduction. This is another boy that was operated at the age of 3. This is how he looked 3 years post-op. And this is how he looks now, about 15 years post-op. He's ortho. He still has some movements of the eye for abduction and adduction. So to conclude, lateral rectus fixation to the orbital wall gives excellent results, which are stable and long-term. The procedure is easy to perform and has no serious complication, and we recommend this procedure for complete third nerve palsy. Thank you.
My name is Dr. Alejandra Santiago. I'm a fourth-year ophthalmology resident at the University of Puerto Rico. I am honored to be presenting today our case, which we title Injection-Related Visual Compromise. I hope you all enjoy it, and I'll take any questions at the end. So first, I have no conflict of interest to disclose. The chief complaint of our patient is a 60-year-old female patient with no past medical or past ocular history who arrived to the emergency department complaining of double vision, dizziness, and periorbital pain. And this was right during a filler injection around her right infraorbital area. So when we further interview our patient, she was referred to the emergency department by her cosmetic dermatologist after the patient developed these symptoms while being injected with hyaluronic acid material. We were able to contact the dermatologist, who referred that she was injected 15 milligrams of Volvella, a type of hyaluronic acid, with a 32 gauge needle. And the symptoms occurred during the injection of the right tear trough area. The patient before this was tolerating the procedure very well, and she was not injection naive. She had Botox and other filler injections in the past, but none had resulted in these symptoms. So when she arrived to us at the emergency department, she had a vision of 20/25 and an intraocular pressure that was normal, 14 and 16. Her pupils were round and reactive to light, and she had no afferent pupillary defect. Her vital signs were also stable, mildly hypertensive, 143/65, but overall within normal limits. So we were interested in this double vision. When we saw her at the emergency department, her nausea and dizziness and headache had resolved, but her double vision persisted. And she described this double vision as vertical and present at primary gaze, but worse at down gaze. So we started by assessing her alignment, and we saw that her right eye, she had a right hypertropia. And when we did her extraocular movements, we saw that there was a right eye limitation in infraduction. The other extraocular movements, horizontal movements and cardinal movements, were preserved. Her force reductions were negative, her color vision was preserved, and her visual fields by confrontation were full in both eyes. So externally, our patient did not have ptosis, but she did have some skin changes around her right infraorbital area, which to us appeared as livedo reticularis, which are findings that suggest possible vascular compromise to that area. Her slit lamp examination was within normal limits, and we also did a full retinal exam, which was normal with no retinal ischemia or optic nerve pathology. So remembering that our patient came in with a possible neurological scenario, we wanted to rule out any intracranial pathology. So we did a head CT without contrast, which fortunately was normal. So let's take a moment here to kind of go over what we have so far. So we have a 60-year-old female with no past medical history, no past ocular history, who arrived referred by her cosmetic dermatologist because she developed an acute onset vertical double vision that was painful during a right tear trough filler injection by an experienced physician. She also had periocular pain and nausea, and on our examination, she had a limitation in the right infraduction, which was suggestive of a limitation in the right inferior rectus, and she had livedo reticularis. No other ocular complaints or findings were found. What is our differential diagnosis at this time? So considering that symptoms started during the injection, we were concerned for a possible injury of the inferior rectus secondary to a vascular occlusion or compression secondary to that filler injection. Also remembering that the injection was done with a needle, we were also worried for a direct injury of the right inferior rectus muscle. And finally, we have a patient that is complaining of vertical diplopia, and we always have to think of a possible fourth nerve palsy, although less likely in this case. So what we did at that time is we recontacted the dermatologist and learned that she actually injected hyaluronidase before referring the patient to the emergency department. So we wanted to know how that evolved. So we patched her right eye and we followed her up 48 hours after, and at that time she did have some improvement in right infraduction, but she still had double vision. So we did a skin ultrasound, which showed a persistence of a hyaluronic acid material, so we referred her back to her dermatologist for further hyaluronidase injections. After that, we also wanted to kind of attack her inflammatory components, so we started the patient on 8 milligrams of dexamethasone for 5 days, and we saw her at a 1 week after that. At that time, her symptoms were improving, but she still had double vision, so we kind of observed for a longer time, and we saw her at a 1 month after the initial presentation. At this time, the patient was very happy. She had no double vision, and she did have some persistence of that right hypertropia, and on down gaze she also had limitation of her right down gaze of her infraduction of her right eye, but again she had no double vision, so she had improved. So right now, reassessing the different diagnosis and the possibilities and remembering the anatomy and what happened, we believe that our patient had a right inferior rectus paresis secondary to vascular occlusion of the infraorbital area. So if we remember the anatomy, and specifically the anatomy of the inferior rectus and its blood supply, it receives a dual blood supply from the infraorbital artery and primarily also blood supply from the muscular branches of the ophthalmic artery. But the infraorbital artery is very close to that tear trough area. So if we don't inject on the right plane, we could result in a iatrogenic injection of the filler material in this artery and actually injury, and it causes cause an injury, to the inferior rectus. And we believe this is what happened to our patient. So filler injections are common and complications are rare. But we were interested in seeing what is the incidence of isolated ophthalmoplegia after these injections. And the reality is that literature doesn't show a lot of patients with this isolated finding. They're mostly associated with other ischemic involvement of the eye. So we love this case because we think it showed how variable injection-related visual compromise can present. And it is important for us as ophthalmologists to kind of know and identify these complications. So I want to thank Dr. Jose Raul Montes, who is my mentor. And these are my references, and I'll take any questions you may have at this time. Thank you so much.
Hello. This talk is about strategic decision-making in ocular traumatology. I have no financial interest in the talk. The eye surgeon's dilemmas in traumatology include the following if we are talking about strategy. The first one is whether to do surgery or not. And a good example to show when you would not do surgery is a hemorrhage as a result of contusion. The next question is if you do surgery, whether you do it yourself or you would better refer the patient to another surgeon. The next question is about timing. You can do a now surgery, which means you do a primary comprehensive intraocular reconstruction, everything from the cornea all the way to the subretinal space. Or you can delay the surgery. One option of delay would be just a little bit of delaying it, which means you do surgery in the first 4 days, or you delay it a lot, which means weeks or months. The final statutory question is the type of surgery you would do. Of course, you would close the wound, clean the anterior chamber from blood, etc. But the big question is whether do you posterior segment work, vitrectomy, yes or no. But so far, we have been talking about acute cases, which means the patient comes to you shortly after the injury. But what do you do when you have a chronic injury? And one good example of this is the following case. It's a chronic intraocular foreign body which was accidentally discovered. The patient has no symptoms, visual acuity is full. In fact, the patient doesn't even know there is a foreign body in the eye. It is a ferrous one, it is encapsulated, and it's sitting on the posterior pole, and here is the image showing the now subretinal intraocular foreign body. The other option, of course, is to remove the foreign body, but as I mentioned, you have surgical risks. Anything from retinal detachment to endophthalmitis, PVR, etc. The best in such a case is to discuss the case in detail with the patient and make the decision together with the patient. You have to tell what to expect in case there is no surgery and what if there is surgery. So in this case, this young man decided to undergo surgery rather than to do regular checkups. So again, you see the encapsulated foreign body, which is close to the macula at the vascular arcade. The first step of surgery, of course, is do a vitrectomy, which must include the detachment of the posterior hyaloid. Even in this case, we are 1 year after the injury. As you can see, there is no PVD. This is very important to realize and not defer surgery at a later stage just because the surgeon expects a spontaneous posterior vitreous detachment as described in the literature, in a few days. You cannot accept that as a fact. Most of the time, even if there is some vitreous separation, it's a vitreous schisis, not a detachment. You can also see that you require not just aspiration, but a sharp tool to detach this very adherent posterior hyaloid. And I want to emphasize it again, you must never leave it on the posterior retinal surface. Step number 2 is to peel the ILM, and I'm using, of course, green dye, ICG, to make it visible. The reason to remove it is because it may be seeded with cells which can get activated after the surgery, and you can have a macular pucker, and then you have to go back and redo the surgery. The third step is a crucial one again. You have to remove the capsule from both over and under the foreign body. If you don't do that, and you can probably extract this foreign body without opening the capsule first, but it has tremendous risks of causing a larger retinal rupture or a choroidal bleeding, because you have no idea how the eye looks underneath the foreign body. You don't know what connections it still has to the choroid. So as you can see, I'm using various sharp tools, from blade to a needle with a hook on it to an intraocular scissors, to make sure that before extraction of the foreign body is attempted, there is no connection between the capsule and the foreign body is left behind. A little bit of bleeding, because as I said, you don't know what is behind, underneath the foreign body. But once it's freed, and in real life it took longer than what you saw in the video, you have to open the sclera, and I always make a fourth incision, not enlarge an existing one, because then it's very difficult to tighten it back to its original size. And the size of the foreign body cross-section will determine the length of the incision, but in this case it's a relatively small foreign body, so really it is the size of the magnet that will determine the size. And you must, as we saw on the video, open the choroid underneath the sclera with Vienne scissors to make sure that the foreign body doesn't get stuck underneath. And then you carefully, very slowly remove the foreign body, because what you don't want is, one, it to drop back on the retinal surface, and two, to get stuck under the wound, because then it's very difficult to find it. After that, you re-suture this wound and complete the surgery, which in this case will include chorioretinectomy. The reason to do that, and you do this with the diathermy probe at its highest setting, is to make sure that no PVR comes from this area. You have to kill the pigment epithelial cells in the affected area. With this, and there's no laser over this, with this final step, air fluid exchange surgery is complete with a gas injection. And this patient maintained excellent vision years after the operation, and you can see that the retina amazingly closed over the impact site. So this case worked as planned, but the question is, what do you do next time when you see a patient with a chronic intraocular foreign body? And there is no absolute answer. You have to make that decision in every case, again, discussing it with the patient. Thank you very much.
Okay, thank you very much. I'm opening the discussion. The first lecture in that part was Professor Morat. Any questions? Any comments?
No.
I have a question. This is not my field of expertise, obviously, but I was wondering why you used Vicryl to attach the muscle to the periosteum because vicryl eventually disappears. And in this case, you have to have a fairly firm, permanent connection between the two tissues, since the muscle will still move. Obviously, it works, but I'm just wondering the rationale behind it.
Yeah, it's a very good question. And the other cases that I showed, I actually used non-absorbable sutures. But some of the patients with time have problems with the non-absorbable sutures. Some of the sutures pops out. So I decided to use vicryl, thinking that after this is a 4-0 vicryl, it takes about 2 months or even 3 months to dissolve. And after 3 or 4 months, I think the muscle will be embedded in the tissue of the orbital rim, and there's no chance that it will disconnect. This is the reason I did that. Actually, I wanted to congratulate you for the surgery. It's excellent, really, the retina surgery. Very nice to see that. And
I have one question regarding your technique. It was also very brilliant surgery. I am not the strabismus surgeon. Any problems with double vision with these kids? Or what if double vision, what you do? Or what you recommend to do?
Well, all the cases that I showed are congenital ocular nerve palsy. And one of was traumatic, but also in a very young age. So all this patient had amblyopia and actual suppression of the deviating eye. So there was no problem with double vision. The last patient from Ukraine, when I brought the eye to the center, he was used to have the eye in exotropia. He didn't feel it. When I brought the eye to the center, he had a period of double vision, but then it disappeared again. So I guess that with acute cases, you have a terrible problem with double vision. Yeah, for sure.
Okay. Any other questions, comments?
Well, hello, Yair.
Hi. Good to see you.
Yes. Oh, I'm not also a motility surgeon. I just, like I was discussing a while ago, that I just treat kids, but I don't really operate in the time. But I think in your case, thinking out of the box is that, doing these things makes an addition to the usual approaches. So I think that was in a way brilliant in my end. So
yes, actually, I didn't mention that the idea was Alan Scott's idea. Alan Scott from the US, he died about a year ago. He's the one who first injected botulinum toxin to muscles, and he had many other good ideas. And this was his idea.
Okay.
Yeah. Thank you for that.
Okay, let's move to the presentation of Dr. Diaz. Filler injections. I think it becomes the reality because many people are having this treatment in the aesthetic medicine. So, any questions, comments, how to deal with this? So, Dr. Diaz.
I have one, but it's not really about the ophthalmology part. When I looked at the images, I just told myself, what on earth is the reason to have a filler procedure done in this patient? Do you have any idea why people would do this? Or this particular people?
Yes, our patient was complaining that she had some hollowness in between, under her eye. She did have previous filler injections, so I think that's why maybe it's not noticeable. I wouldn't injected her myself. But of course, this was done by a dermatologist, cosmetic dermatologist, outside of our institution. But we found what we found most interesting was that she only had that isolated ophthalmoplegia, and when we were revising the literature, it was mostly when people were complaining of ophthalmoplegia after a filler injection, it was associated with central retinal artery occlusion or anterior segment ischemia. So fortunately, our patient didn't have other signs of ocular ischemia, but we think that it was mostly like the infraorbital artery that was just iatrogenically injected during that tear trough injection. I agree. I wouldn't have done it myself.
Did you use, or did they use hyaluronidase, and was it helpful?
Yes. So when the patient arrived to our emergency department, she had received previous injection with hyaluronidase by her dermatologist. We had to resend her to get more hyaluronidase injections when we saw her at 48 hours because she did have some still material, like filler material around her tear trough area. But we think it did definitely help. We also prescribed her with steroids because she was very inflamed. So maybe it was the combination of both. But we definitely think there was some ischemia because she did not regain complete movement of that in inferior rectus.
Mm-hmm. Any
But
other questions?
We definitely think it helped.
Okay, thank you. Any questions, comments?
Yeah, I have one final question. Has
on.
anybody invented brain filler?
I think we are still in front of
Working
this
on that
idea.
That's a bigger problem.
We are working. Okay, we are working on artificial intelligence, not natural stupidity. That's the problem. Sorry, I am not politically correct. Dr. Morat, please.
Yes, just I wanted to ask, did you consider putting a Fresnel prism on the eye, on the glasses to avoid the diplopia? Because what we see, we see many times where there is some trauma to the inferior rectus, in 90% of the cases, it heals by itself and the movement comes back. The only thing is the diplopia, and Fresnel prisms can help. So, yeah.
Yes, we did consider it in the beginning. We also wanted to see if she did improve on her own. When we saw her at a few weeks after the initial injection, she was not complaining of double vision on primary gaze, and she neither on down gaze. So we didn't think there was a need, just because we wanted to preserve that primary vision and like looking down. But it was something we were considering with our neuro op to kind of do it together, or maybe like pediatric specialist, because she did arrive to the oculoplastics clinic.
Okay. Okay, thank you. Let's move to the trauma lecture. It was brilliant. Thank you, Ferenc. The floor is open for the discussions. Any comments?
Hi, Ferenc Kun.
Hello.
Yes, I was your student in EVRS 2011. It's nice to see you again. And I think we also invited you for the Philippine lecture about during the pandemic. And now the usual thing that I noticed when we have these trauma cases embedded in the retina is that, just a side, maybe just a comment I noticed, that we end up with some of our instruments being mangled and probably being destroyed, the tips in a way. So in your case, was there a lot in your hands?
You mean the instrument
the instruments that you use? Yes. When removing
destroyed?
Yeah, sometimes, because here, like the tips.
You mean when you open the capsule?
Yes.
So yes, but in this case, the capsule was not so firm. But you're right, if you use a very fine intraocular scissor to open a very hard capsule, that can damage. So that's why I used the scissors not to open it. I opened it with a blade. And I also used a needle to try to move away the connections between retinal, choroid, foreign body, and capsule. And certainly you would not use a scissors that is not disposable for this. You're absolutely right.
Ferenc, do you use, because there are, for the big foreign bodies, there are a sort of baskets when you can put them and then remove. Did you use this, and what's your opinion about
I don't have such a forceps, so that was not a question. But in such a case, it would be equally as good to remove it as the magnet. If it's not a ferrous magnet, foreign body can use a magnet, then you have two options, either that basket, but very few people have that kind of forceps. So in that case, probably a better option than using the diamond dusted forceps, for example, would be a lasso that you can put in through a needle to hook it around the foreign body.
Okay.
But the main thing, again, two main things as takeaway messages is never assume there is a posterior vitreous detachment. And second, never try to rip the foreign body out with any kind of force without being completely free from all the connections to every neighboring tissue.
Yeah. Okay.
May I?
Any? Okay. Yes, we have to finish. I know.
This is the opportunity we have as personal friends conference with us, and what Perfecto mentioned. Well, I also feel a pupil of Ferenc. I've also been at the EVRS also. I mean, there are many people. I mean, in Poland.
I am the one.
Yeah,
I am the one also.
Have to say, Professor Kuhn, our dear friends, he put so much really time and effort for education. I can speak about Poland. We really feel very grateful for you. I mean, this is you certainly deserve not only a medal. I mean, but just a monument. I mean, for propagating really very high quality vitreoretinal surgery and very responsible, let's say, way of thinking about that. So really, just to say this, to add this to this session. Thank you so much for being with us.
Thank you.
Thank you. Not mentioned. Okay, go on.
Just one sentence. I think what is crucial when you have obviously a lot of experience after all these decades is to share them. And what I like to teach is not so much as how to do something, it's how to think. That's the most important thing.
I would like to recommend strongly your book, Vitreoretinal Surgery Strategy and Tactics. It's still on the shelf in our OR, and it's used all the time.
Thank you. And it's wonderful to be with you, even if it's only online.
Okay. Thank you so much.
Thank you.
Thank you so much for the wonderful presentations. And Andrzej, the floor is yours. Thank you. Because we have to move to the next session.
Now we move to another session. So I would like to thank you so much for making this session so interesting. Now we need to move to another session. May I ask to show the screen presenting the moderators? Well, this is probably not very complicated, but at first I would like to introduce my co-moderators. I see Professor Karla Lanka is with us, and Professor Jari Murat was already very active in the previous session, so he is also a co-moderator. We will have now the session on myopia, new therapies and methods. And here we will have a few cases. The first case report by Dr. Michelle Beach from UK. Then the Dr. Philip Hassler from Germany will present another presentation. Then Dr. Nadia Fernandez from Portugal. And finally, Professor Jari Murat, but instead of Dr. Alan Achimor, because, Professor Murat will explain why he could not do it by himself. So let's listen to the lectures now.
Hello everyone, my name is Michelle Beach and I'm an optometrist from the UK. I set up Heart Vision in 2008, having graduated from Cardiff University in 1993, which seems a long time ago now. I finished my training in the eye department of Queen's Medical Centre in Nottingham, where I specialised in low vision aid children's clinics and corneal research. I'm passionate about sport and practice sport vision, seeing elite athletes all over the UK. I also have a love of children and did my school vision diploma, which leads me to see many children with dyslexia and binocular vision anomalies in clinic. I am a key opinion leader for Menacon, Alcon and Hoya. We see a huge range of patients at Park Vision, from the young to the old, but obviously with so many children coming through the door, our myopia management patients are growing rapidly, and we fit a variety of complex ortho-K patients as well as practicing with scleral lenses. We absolutely need the technology of topography, and we use this very heavily with all our myopia management patients for obviously axial length measurements, ortho-K patients, and even our contact lens clinics to assess contact lens fits and to make sure that we get the best possible outcome for our patients. I'd like to talk to you today about one case that we had that perplexed us a little bit, and this patient was a 16-year-old male called Finley. Finley came to see us for the first time in April, dragged through the door by his mother because she said he was squinting through his glasses. We hadn't seen him before, but he was wearing spectacles that he thought were about a year old, as you can see, about -1.5 right and left. On refraction, Finley was -250, a progression of about a diopter, which we feel was probably in about a year. So although Finley was 16 and possibly a little bit late to practicing myopia management, he had still progressed by a diopter in probably about a year, 18 months. And so obviously we needed to act on this. We had a long chat with Finley about myopia management and to prevent his prescription from getting any worse. We discussed myopia management glasses, contact lenses, and also the option of ortho-K. Finley absolutely jumped at the idea of ortho-K. He hated wearing his glasses, and as his mother agreed, he spent most of his time just walking around the house squinting. We did topography on Finley to get a clear picture of his cornea, measured axial length, and ordered his first pair of ortho-K lenses. Finley came to clinic on the 11th of April for his initial fit, checked that he could remove and understood lens care, and then was booked to return to the clinic first thing the following morning on the 12th of April, having worn them for the first time the night before. Finley bounced in, excited about the fact that he could see, hadn't worn his glasses into clinic, and was absolutely delighted. On refraction, you can see that his right eye had really started to change, -0.75, but we're a little disappointed to see that there wasn't as much progression in his left. But it was early stages, he'd only worn the lenses for the first night, his corneas were nice and healthy, he'd managed the lenses well, so we decided to book him for a review in a week's time, hoping to see great results. Finley returned to clinic a week later, absolutely ecstatic about his vision. He hadn't worn his glasses for a week and said his vision was amazing. As you can see, we were a little bit disappointed because his right eye was completely perfect and his left eye was -175. Finley hadn't actually noticed this, and it wasn't until we covered his right eye that he noticed his poor vision. We did topography on Finley, and we were just a little bit concerned, as you can see, about the deep sort of marking on the peripheral cornea that looked like perhaps there was something going on with the wearing of his lens. Slit lamp imagery with fluorescein completely correlated with what the Maya told us. We could see that there was perhaps some pressure going on in his peripheral cornea with the staining that was reflective from what the Maya was picking up. So clearly there was something happening here. We were disappointed with his spectacle RX, and the fit of the lens didn't look quite as good as we would like it to have done. We discussed compliance with Finley. How was he wearing the lens? Did it seem to be staying on? Was it comfortable? Was he sleeping with loads of pillows that were possibly pressing on his eyelids? Was he sleeping face down? Was he sleeping on one side? Was he getting enough sleep? And was he actually remembering to put the lens in? Or had he not put the lens in at all and suddenly remembered the night before his appointment? His mum was monitoring his lens wear and seemed to think that he was complying and he hadn't noticed any issues. The Maya is clearly showing us that we're not getting much progression in his left eye. We decided that due to the fact that he was also getting staining, we wouldn't wait any longer and we would change the left lens. I felt that the lens needed to be flatter at the periphery and apply more pressure in the central zone to see if we could get rid of some of the myopia that still wasn't changing. The lens was ordered, we waited for the new lens to come, and then we decided that we would monitor Finley quite closely over the next few months. Finley's lens wear was excellent. He wore the lenses every night, closely monitored by his mum. As he came in through June and July, we really thought things were starting to happen. Finley was absolutely still delighted with his lenses because he felt his vision was excellent from where he'd been. In July, we thought we were finally cracking it. His prescription had halved and we seemed to be going in the right direction. And then we're bitterly disappointed when he came back in August to see that he'd got worse again. And we didn't seem to be controlling the myopia in his left eye at all. We went back to the lens manufacturer with the topography images and the Spectacle RX and had a discussion about what we thought we should do next. We clearly felt that we weren't getting anywhere with his left eye and we needed to act on this. On the recommendation of our lens manufacturer, we stopped all contact lens wear in his left eye so that we would achieve a washout period of a month and let the cornea completely return to normal. We would then reperform the Maya once the cornea had recovered and reorder the lens. There was discussion about the diameter of the lens and perhaps we needed a slightly smaller lens to take the pressure away from the periphery of his cornea and act better in the central zone. At the moment, we are still waiting for that lens to come in, and Finley is still happy because he thinks his right eye vision is perfect. It'll be very interesting to see when we get his new left lens if we can achieve plano in that eye and give him the great binocular vision that I would like him to have. Thank you for listening. I really cannot recommend using topography. The Maya massively helps us in our contact lens clinics and ortho-K journeys.
Dear ladies and gentlemen, it's an honor for me to talk to you today. My name is Philipp Hessler and I'm optometrist and researcher at Ernst Abbe University of Applied Sciences in Jena, Germany. And I'd like to welcome you all to this myopia management case presentation. My case deals with an 8-year-old girl. She came to me because she can hardly see the blackboard at school, so it is not an unusual problem, but rather something we are faced with every day. There were no further diseases, no medication, and no further complaints. And based on the age and the problems described, we therefore suspect that myopia may have developed. The first thing we then do in practice is to take a measurement with the myopia master from Oculus. And this is a biometric system that is specially made with a software for myopia management. It measures the objective refraction, keratometry, and axial length of the eye. And these are 3 important parameters that we need in order to assess myopia more accurately. In the result, we first see the axial length of the eye on the left-hand side. And this is 22.6 millimeters, which is not particularly noticeable at first. But the percentile curve on the right-hand side helps us to classify whether this axial length, 22.6 millimeters, is normal for that age. And there we can see that our patient is just below the 50% percentile. And this means that the axial length is completely normal for her age. The refraction shows a low myopia of around -1 diopter. Now, it is important to look at where the myopia comes from. And first of all, it is interesting to know whether it is axial length myopia or a refractive myopia. And the GRASS module, that is Gullstrand Refractive Analysis System, helps us with this. And by measuring refraction, keratometry, and axial length, the software can precisely calculate whether the refractive error is caused by the length of the eye, by a deviating corneal refractive power, or by the crystalline lens. And to do this, the individual components are calculated using an age-correlated Gullstrand eye. And in this case, we see that the axial length has no part in the myopia at all. The myopia here is mainly caused by the corneal refractive power being too high. And it is therefore refractive myopia in this case. Risk assessment is the key to myopia management, and it is very important to assess the risk of further myopia development. And there are many scientific concepts for this. In this case, we see one myopic parent and all other risk factors such as time outdoors, time with near work, and all the parameters dealing with binocular vision, accommodation, and versions are all unremarkable. So the risk of further myopia development can therefore be classified as rather low at this time. So the question of all questions is, do we need myopia management at this point? And for me, the answer is no. We recommend cycloplegic refraction first, and if necessary, a classic distance correction. A checkup should take place in about 6 months. In this case, the patient came 8 months later, and the axial length is 22.9 millimeters. The refraction is -2 diopters. And if we look at the percentile curve, we can already see that something is not going as we might have expected. A clear increase in axial length and a clear increase in myopia. At each follow-up measurement, it is important to calculate the annual growth rate. So we can use the annual growth rate to assess whether the eye has grown too much or normally. And here we see the curve from Trockenbrot et al. From 2021, and this is used in this case. Here we see the annual growth of emmetropic patients as a function of age. So the myopia master also calculates this annual growth rate. And here it is 0.42 millimeters calculated over 1 year. And if we plot this on the curve, we can see that this is significantly too high. Normal growth at this age would be around 0.2 millimeters per year. So we need to start myopia management now. Yes, we should do this. And we choose orthokeratology treatment, which studies have shown to be a very good way of reducing the annual axial length growth. So another year later, the axial length is 23.2 millimeters, and we see that the red area on the right, this red area shows us the period of the treatment, and the curve is slightly flattened. But is this effect sufficient? That's the question here. In order to assess whether the effect is sufficient, we must again have the annual growth rate output by the myopia master. And this is now 0.3 millimeters. So we enter this value into the Trockenbrot curve, and we see that we have already been able to significantly reduce the growth rate, but we are still above the 50% percentile. So we are still not doing enough. Our therapeutic effect is not sufficient. So what we can do to increase the therapeutic effect? It's not successful at all. So what can we do? We have two options. We can use low-dose atropine eye drops in addition to the orthokeratology treatment. And however, this would be our second choice here. With orthokeratology, we have the option to reducing the optical zone in order to achieve more plus addition. It should be noted that a smaller optical zone can cause more halo or glare, and that the quality of vision in dark light conditions is a little bit poorer. However, This should not be a problem for a child under the age of 10. And if in doubt, you can briefly measure the pupil diameter. And if the pupil is very large, you may need to consider other therapeutic options. We have therefore reduced the optical zone from 6 millimeters to 5 millimeters. And again, 1 year later, we see an axial length of 23.3 millimeters. And we see the color on the right-hand side that has changed now. And each change of the color is according with another therapeutic option. So the curve continues to flatten, and the question is again, is the effect now sufficient? The answer is yes. So we see in the curve of Trockenbrot et al. That we are well below the 50% percentile. And with this treatment, we have achieved the goal of our myopia management. So our aim is always to reduce lens growth to immetropic eye growth. So we can continue with that myopia orthokeratology treatment here. So our take-home messages. Percentile curves for age-dependent standard values for axial lengths are only useful for risk assessment at the first appointment. From the second date onwards, we should use annual growth rate. So we have to calculate annual growth rates every time from the second date on. And the goal in myopia management is the annual growth rate of an immetropic eye. So we achieved this here with our treatment orthokeratology and the smaller optical zone. So smaller treatment zones can enhance the effect of orthokeratology in myopia control, and alternatively, additional atropine eye drops, 0.01%, can boost reduction axial elongation if the effect of optical myopia management options is too weak. So thank you for your attention.
Good afternoon. Welcome to my presentation. My topic today is Low Vision Rehabilitation Program in Myopic Macular Degeneration, a case report. There is no conflict of interest with the subject matter addressed in the presentation or with any equipment and software mentioned. Pathologic myopia is one of the most causes of irreversible visual impairment in developed countries, and patients are at risk of myopic macular degeneration. High myopia increases also the risk of open-angle glaucoma in elderly population that are affected by a loss of quality of life. So low vision services should offer specialized training programs for these patients. At an ophthalmology clinic in Portugal, we developed the low vision rehabilitation program for 8 weeks that was divided into phases. In the first phase, we stabilized the preferred retinal locus, and the second phase with training with low vision hands to improving reading ability. We defined pre and post rehabilitation measurements, such as best corrected visual acuity, contrast sensitivity, reading speed, and face recognition. For the aim of this study was to evaluate the outcomes with the low vision program in a patient with UMND. A 69 years old male is included in this study. He was moderate visual impairment with a MMD category 2. Was diagnosed with open-angle glaucoma and began to be treated by our ophthalmologist with latanoprost and timolol maleate, and with high health supplementation by citicoline and RX2 formulation. We use SDOCT to diagnose and monitor our follow-up. And in this image, we see a diffuse chororetinal atrophy with no macular schisis or with no choroidal neovascularization by ATN classification. We adapted a relocation prism followed by a portable electronic magnifier and glare control filters in our low vision rehabilitation program, and we obtained an improvement in all visual function and functional visual outcomes measured after 8 weeks. Although we cannot, it was not possible to do octopus perimetry before low vision rehabilitation intervention, but we did after 6 months of PRL rehabilitation, a low vision central program, and it demonstrates a retinal sensitivity of 33 decibel in the fixation area. After 1 year, we reevaluate again our patient, and we observe a stabilization of contrast sensitivity value and the better values in others outcomes. For monitored our intervention, our glaucoma treatment intervention, we did SDOCT, macular thickness map, that showed discrete improvement in macular ganglion cell complex that could be observed in these graphics. There was a discrete improvement also in disc maps of the SDOCT, but we should be carefully interpreted these values because the artifacts and low signal acquisition typical in high myopia patients. We can conclude that low vision rehabilitation intervention was beneficial in improving visual function and functional visual outcomes with no side effects on structure and function. The level of improvement depended greatly on the patient's retinal integrity, visual acuity reserves, and commitment with the rehabilitation process. Open-angle glaucoma is a vision-treating condition that should be diagnosed and early treated with neuroprotectors for a better management and improvement in visual function. Longitudinal studies are necessary to ascertain the long-term efficacy of low vision rehabilitation, which must include both the quality of life questionnaire and to correlate macular structure and function pre- and post-rehabilitation. Finally, I'd like to thank our research team that is involved in this project. If you need any further information, feel free to contact me by an email. And thank you for your time.
Dear friends, as you know, in October 7th this year, Israel was attacked from Gaza, and we are at war right now. Unfortunately, Dr. Alona Chimor, who was supposed to give this presentation, is fighting in Gaza right now, and he asked me to give this presentation on his behalf. And let us all pray for peace in our region as soon as possible. I'm going to speak today about high myopia in a Bedouin pedigree. The case presentation is of a 1-month-old baby from a Bedouin origin, born full term, with perinatal history, which was unremarkable except for jaundice, which disappeared without any problems. And she was admitted to the pediatric emergency due to high fever. The mother describes several episodes of ocular flutter that, as you see in this video, during the last week. And when the pediatrician saw that ocular flutter as well, they decided to call for an ophthalmological consultation. The ophthalmologist who came to see this baby also noticed the ocular flutter. He also saw normal anterior segment in both eyes, but when he looked at the fundus, he saw atrophic retina with absent macular reflex. So he decided to do an EEG and brain ultrasound and to follow up within 1 month. 2 months later, the mother and the child arrives to our clinic, and she's smiling. The ocular flutter is resolved, the EEG is normal, the ultrasound brain is normal, and the baby fixate and follow normally and with orthophoria. We examined her, and here you can see the fundus pictures from both eyes. You can see that the retina is very flat with absent macular reflex, and the surprise was the refraction, minus 12.5 OU with axial length, which is very long or very big for babies, 23.8 and 23.6. So we recommended glasses, of course, minus 11 in both eyes, a little bit of undercorrection, ERG and VEP, genetic counseling, and follow-up in 3 months. The next time the mother arrives is when the baby is 6 months old. She's done the ERG and the VEP, they're all normal. The ocular exam is unchanged, and we decided to send a genetic panel to Blueprint Genetics. This is the company in Finland that is doing genetic testing for cells from the palate. And in perfect timing, the same time, arrives another patient to our clinic, 33-year-old male with high myopia, minus 24 OU. In this left eye, he had a retinal detachment at year 2006, and he had paraspinal vitrectomy, lensectomy, and scleral buckle. A year later, he developed corneal edema and undergone a PKP. And in the right eye, he undergone prophylactic laser treatment and is developing myopic CMV. His ocular exam in the right eye is the vision is normal 6.9, normal anterior segment, and myopic fundus with lacquer cracks. And in the left eye, the vision is 6/90 with corneal haze, aphakia, and fundus that cannot be seen. And this is the picture of his right eye. You can see the flat retina, the absent macular reflex, and the laser birds in the periphery. And this is his OCT. You can appreciate the myopic CNV. And surprise, surprise, our patient is the baby's cousin. So we decided to send another Blueprint genetic panel to see if we have any results. And then the plot thickens. A month later, 2 siblings from Bedouin origin arrived to our clinic, an 8-year-old girl and a 3-year-old boy, both diagnosed with high myopia. This is the boy and this is the girl, and they have the same family name. So of course, we do the genetic testing again and do an EUA to the boy. You can see lens dislocation in both eyes, mild cortical cataract in both eyes. His visual acuity is very low and his refraction is minus 15 in each eye. And this is his fundus pictures. You can see that they are very similar to the pictures we've seen so far. And this is the sister, 8-year-old girl, cortical cataract in both eyes, lens dislocation in the left eye. The visual acuity is also low, and refraction is minus 14 in the right eye and minus 20 in the eye with the lens dislocation. And the fundus pictures are very similar to what we've seen so far. And a week later, we get the result from the first patient. Later, we got the same result for the other patient. It appears that they are all homozygous carriers for a pathogenic mutation, which is known. I'm not going to read all these letters to you, but a quick search in Medline revealed the name of this mutation, LEPREL1, and we are surprised to find out that the same mutation was already described in a Bedouin family in Israel, in the south of Israel, with the same manifestations: cataract, peripheral retinal degeneration, and retinal detachment. And here you can see the family tree of this family, and you can see that as known in the Bedouin culture, consanguinity is very common, and this is the result of this consanguinity is many patients in old families. You can see cousins marrying each other, and they all had lens coloboma, lens dislocation, cataract and retinal detachment. Another family was described in China. This is the same mutation, and you can see in the pictures here that the phenotype is very similar with cataract, retinal detachment, and degeneration and empty vitreous. In another study on 298 families in China, they found 70 variants of the same LEPREL1 mutation. So this is a very common mutation in high myopia patients. A study done in mice shows that the basic defect that this mutation is causing is a defect in the collagen production, type 1 and type 4. And since type 1 is related to the sclera and cornea, and type 4 is related to the lens, we see high myopia, cataract, and lens dislocation. And recently, another study from Saudi Arabia, 10 patients, 8 of them females, 80% had cataract, 30% had cell lens dislocation, and retinal detachment in another 50% of the patients. And the same mutation, of course, which is interesting that Saudi Arabia and Israel, they are very far, but still the Bedouin origin shows the same mutation, so maybe the same stem genetic father. And what is interesting about this family is urinalysis in 9 patients revealed microhematuria and mild proteinuria. And this is also something that we need to look at in our patients. So in conclusion, this case presentation emphasizes the need for genetic testings in children with high myopia. This can allow us to do preventive measures like laser against retinal detachment, and also to investigate other systemic problems like the kidney problems that we found in this kind of mutation. Thank you so much.
Thank you so much. We are lucky to have all of the speakers with us, as I notice. Hope that there will be no technical problems. Also, I cannot see them. Hope that they are still with us. Our co-moderators are here. So we can start. Oh, yes. We can start with the... oh, hello. Yes.
Hello.
I still do not see the first speaker because it would be natural to start with the first presentation. So I see that, oh yeah, hello. Okay, so the first paper is open for discussion. Are there any questions or comments from my co-moderators, please?
Yes, I have a question. First of all, a general comment. Thank you for all presentations. Very good. The first two, especially showing 2 simple cases that when we observe the results, they are not so simple to manage. So for the first presentation, Michelle, I have 2 questions. One is I would like to know if the refraction was done with cycloplegia. And the second one, I noticed that there was no other complementary exams like retinal photos or OCT. So I wonder if you did that because the asymmetric progression of the patient is of concern because normally progression is similar between the 2 eyes. So you had a very special case.
Yeah, hi everybody. Yeah, it was really interesting. Yeah, all our patients have fundus camera OCT imaging done. It's standard in the clinic. So yes, all of that is done. I was only told I could do 8 slides, so we couldn't keep putting everything in. But yes, it was done. And cycloplegic refraction is done on all our any myopia management cases standard as well. So yes, absolutely. He is really interesting. He's the only one. They asked us to bring something unusual. And we're even wondering if it's lid fit, is one of his lids looser than the other, or, because it just didn't make sense to the point that, as I said in the presentation, we were questioning, was he actually wearing the lens? But you can see the difference in the topography, and it didn't make sense at all. And so he actually collected his new lens yesterday. So he's coming back to see us. He's coming back to see me tomorrow morning in clinic. But yes, OCT is normal. Fundus examination is completely normal. Cornea is normal. And he was cycloed in his very first initial visit, because we cyclo all our myopes. And axial lengths were, everything's done. So it was a bit of an unusual one and perplexing, because we've changed that lens twice now. So we're really not quite sure. The only thing that they are slightly thinking about is lid anatomy, perhaps, or the way he sleeps. Is he particularly sleeping on one side, which is pushing the lens for some reason? But it's slightly perplexing, and I'm interested to see what's going to happen with him.
Thank you.
Thank you. Any other questions or comments from, let's say, for others? If not,
Just that we're very curious to see the results. What's happened with
I know, so am I. I mean, the funny thing is he thinks it's amazing, because of course his dominant eye's been corrected, and so he didn't even notice that he was still minus 150 in that eye. But of all of the cases we've done, we've not had one that, despite changing a lens and doing everything, has just not moved. So if anybody has any insights for me, I would be grateful. That maybe I'm missing something.
Maybe an OCT of the cornea. Maybe there's something in the cornea.
Yeah.
Prevents. Yeah, could be.
Yeah.
Elasticity of the cornea. I can't remember the name of the device that examines the elasticity of the cornea. That also can, or maybe even the corneal thickness. Maybe the corneal thickness is different.
Yeah, picometry on him. Absolutely. Yeah.
Thank you. So now we can move to the second presentation. Dr. Hessler is with us, of course. And do you have any questions for the second one? Yes, Carla, please.
Yes, I have a question. Thank you for your presentation. Also, a very nice example of, it looks so simple in the beginning, but later on your risk prediction failed. So my question is, you did a risk assessment. So in the first time, it looked like it was a very low risk patient. But after you've seen the patient a second time, he actually progressed a lot. So my question is, in future, if you have low risk patients, do you consider to start treatment, or you still wait to see what is going to happen to the progression?
Thank you for your question. Generally, we are not planning to do that therapy very early. So we are waiting till myopia is going on, but because not all myopes, are progressing. And I think we should very carefully discuss whether treatment is here a way that we should go or not. Not generally.
Yeah, it was a provocative question, because the low risk prediction.
I think discussion with the parents is very important, because the difference between -1 and -2 is big. I mean, -1 you can perform without glasses. -2 not so much.
I see.
Today, when we don't have to do treatment with drops or contact lenses in a small child. We can give her glasses. The glasses. I think the glasses is the way to go. And the only problem with the glasses is the cost. So you need to discuss this with the parents. And if cost is not an issue, I would go for the glasses from the beginning. Why not?
Yes, I see that point. Yes.
Can I?
Yeah.
I think that's quite interesting. But I had the same discussion with a child the other day whose parents is -7, and the child is on cyclorefraction is -0.5 at 4 years old. And we talked about myopia management glasses, which obviously there's a cost, but the child's at playgroup. And of course, these glasses only work for 10 hours wear. And is a 4-year-old in playgroup that's -50 going to wear them for 10 hours a day? Because in their world, they don't. It's not going to make any difference.
Well, actually, in this case, I would start with drops.
Yeah.
Because he has -7, both parents, and he's 4-year-old.
Yeah.
I would go for drops.
Yeah.
And even not 0.01, but 0.05.
Yeah.
Sure.
By the way, may I, from the floor, what do you think of 0.01% atropine? Because lately there was a study published from the US and they found no difference from the placebo. So the question is, do you think that we should use higher concentration, and how long in time?
Are you asking me?
I'm just asking all of you because I'm confused.
Yeah, we could speak on that. I mean, next 1 hour, but
but just give me the clue.
Controversial issue, that right recently, and finally, we do not understand well the results of this study. I mean, of course, we know for a long time that the lowest dose atropine is of relatively weak, let's say, effectiveness. So it is not. That's why we in cases with the progression we know, of course, that it's dose dependent, so we increase the dosage, and we switched recently into 0.05% in majority of cases with no side effects. But still, I don't understand why the study showed this results, because, of course, on the other hand, we have many other studies showing completely different. Even the same year, we have a CHAMP study showing completely different.
Yeah, I know.
So that's why I'm asking on the first part. But of course, I mean, Jiao, Carla, please comment on that. Yeah.
Yes, I think this is only one study, but from our experience, I'm using atropine since 2017, and I see the effect. I see it on my patients. So there's no. I'm sure that this atropine 0.01 has an effect. The thing is, you need to consider two things: what if the patient is high risk or not? For me, high risk is myopia below the age of 10. I usually start with 0.05, and we have 2 myopic parents, also 0.05. And also you can put the axial length on the charts. Today you have websites that are free. You can put the axial length on the chart and see where the child is on the percentiles. If he's very, very high, I would go for 0.05.
Okay.
Sure.
Yes, I agree. If it's a very young patient with a higher risk, then 0.05. Yes, I agree with all the comments.
Okay, thank you.
Let's move to another presentation. We have Dr. Fernandez with us. So do you have any questions or comments to this presentation?
I can ask a question. So my question would be, this is a very interesting case, because normally when patients reach this stage, there's no much options to offer, but patients keep complaining that they don't see well and they would like to improve. So my question is, can we offer rehabilitation programs to all MMD patients, or we need to choose them based on some criteria? Can you let us know which are the criteria, and if disease progression is important or not?
Hi, good afternoon. Thank you for your question. The criteria is related to the impact of the AMMD on the functional vision of our patients, and about the difficulties that they reported to us in daily living activities. But if there is, for example, a choroidal neovascularization treatment undergoing, we waiting for the treatment is done, and after the patient is reporting for our low vision rehabilitation program. But the main criteria is the complaints of the patients in daily living activities about reading, writing, glare, and so on.
Thank you. I think we need to move on because we are a bit time now. So there's a last presentation nicely presented by Yari. This is very sad. What of course, I mean, we pray for the peace in Israel. We are with you. I mean, are there any questions? Well, I have one question. I mean, how expensive is the genetic testing you use? I mean,
actually, I have to say I have no financial interest, but this firm, Blueprint Proteogenetic, is fairly cheap. It's $400. It's not very expensive for the patient. If the patient pays by himself, it's $400, and they have excellent results. I'm very happy with this company.
Thank you. We have time for one more question, if there is any. Yes, Carla, please, because I see.
Yeah. If no one has a question. Yeah, so I'm just very interested in know the results from the 2-month baby, because you had some data, but I don't see any data on visual acuity. So I wanted to know if you did any preferential looking to have any idea of how the visual function is at the moment, because it's a so small baby. So
Yeah.
I'm concerned with the development of the baby in future.
Actually, now she's like around 1 year old, and she's acting normally with the glasses. I mean, she's fixating, and we didn't do preferential looking groups. Actually, I didn't think it's going to be a problem. Maybe in the future, maybe if the myopia, if the lens will develop cataract or dislocation and things like that, we might have problem with vision. But for now, we did the EUA also on the 3-year-old boy. We thought, and also we examined the retina of the 8-year-old girl, because we thought maybe to do a prophylactic laser. But the retina looks pretty good for the time being, so no need for that. With just glasses, and then we'll see what happens.
Thank you. I think that we can transfer this discussion. I promised to organize another meeting on myopia next year. You remember we had a meeting on myopia, whole meeting, the few hours only on myopia, and it gathered, just to remind you, over 650 people from all over the world. I mean, over 20 countries. It shows how there is how big interest is around the myopia, let's say epidemiology, risk factors, control, everything. So I'm pretty sure that we could really continue this discussion for next hour or hours, but we will be back with this subject in June. In June, we organize myopia meeting online, of course, for a global meeting. So at the moment, I would like to thank all of the speakers for great presentations, our moderators for this session is Carla, Yair, and Agnieszka, who stayed with us, and I see that Perfecto is probably also still with us, people who support our meeting for years. Thank you so much, and have a nice evening.
Thank you.